Okay, first we have embryology. Lung development occurs in 5 stages. 5 stages. It begins with the formation of the lung bud from the distal end of respiratory diverticulum during week 4 of development. Every pulmonologist can see alveoli. So that's embryonic, pseudoglandular, canalicular, saccular, and alveolar. So embryonic is 4 to 7, 5 to 17, 16, 25, 24. I don't know if these numbers are important, but let's see. It occurs in 5 stages, begins with the formation of lung bud from the distal end of the respiratory diverticulum during week 4. So starts with week 4. Then embryonic is weeks. So embryonic weeks 4 to excuse me, 4 to 7. Here, what happens? The lung bud, trachea, bronchial buds differentiate into mainstem bronchi, secondary or lobar bronchi, and tertiary segment bronchi. So lung bud to the bronchi is formed here. Actually, I should use this image. So lung bud up to the terminal segmental bronchi is formed. Errors at this stage can lead to tracheoesophageal fistula. Then we have the pseudoglandular phase. Here we have endodermal tubules differentiating into terminal bronchioles. So these terminal ending branches are at the second stage, 5 to 17. Surrounded by a modest capillary network, respiration is impossible and incompatible with life. Next, we have canalicular phase. Here, terminal bronchioles, which formed here, are now differentiated into respiratory bronchioles and alveolar ducts. Surrounded by a prominent capillary network. Airways increase in diameter. Pneumocytes, I think this is high yield. Pneumocytes develop starting at week 20. Respiration is capable at week 25. So yeah, if we really need to deliver respiration capable at week 25, so that we at that point. Next, we have saccular phase. This is when alveolar ducts differentiate into terminal sacs. Terminal sacs are separated by primary septae. Then we have alveolar phase, where the terminal sacs differentiate into adult alveoli. So this is between 36 weeks to 8 years. So due to secondary septation. In utero, breathing occurs via aspiration and expulsion of amniotic fluid. There's increased pulmonary vascular resistance, as we know this is the high yield fact, increased pulmonary vascular resistance through gestation. At birth, air replaces fluid, so there's a drop in pulmonary vascular resistance. So at birth, this is the main thing. Air replaces fluid, there's a drop in the pulmonary vascular resistance. So image review, we're seeing first embryonic phase. Actually, let me use the UL one first. This is much better. Okay, so here embryonic 3 to 5 lung bud forms the trachea and the bronchi. So that's the main thing. Pseudoglandular 5 to 16. Here endodermal tubules differentiate into terminal bronchioles. So terminal bronchioles are formed at this phase. Canalicular respiratory bronchioles develop and capillarization occurs. Saccular is 26 weeks to birth. This will be alveolar ducts form terminal sacs. Pneumocytes begin producing surfactant. So this is high yield. Pneumocytes begin producing surfactant in the saccular phase, which is 26 weeks to birth. Alveolar, so that's why if they have to, respiration is capable at 25. So around 25 to 26 is kind of relatively okay. Then we have alveolar phase, which is 36 weeks to 8 years. Alveoli undergoes septation and proliferation all the way up to 8 years, which kind of explains why kids may be more susceptible to infections, because the alveoli are still developing. They're still maturing to adult alveoli. So again, here also it shows first is embryonic phase 4 to 7. It forms the lung buds and the trachea up to the segmental bronchi. Pseudoglandular is endodermal tubules form the terminal bronchi. Then canalicular. Then respiration is capable at 25th week. I think this is most high yield. And this is in the end of canalicular and beginning of saccular phase. Surfactant starts to be produced at 25th week. Yes, with the concurrent with the saccular phase. Birth at 38, and there's still alveolar maturation all the way up to 8 years. Okay, so pneumocyte starts developing at week 20, respiration capable at week 25. These purchase, that's most important. And what phase? That's the saccular phase. Okay, then next we have choanal atresia. What is choanal atresia? This is blockage of the posterior nasal opening often associated with bony and abnormalities of face.
Sorry. I have a question. Here, they say question is surfactant production starts where? In canalicular or saccular?
I think I would go with saccular. That's what UOLD has. Because here they've said surfactant, pulmonocytes begin producing surfactant at 20 saccular phase. So here they said pneumocyte starts developing at 20 weeks. So I think UOLD had saccular, like the answer for this exact image. That's where I took it from.
Okay, so saccular phase are surfactants, right?
Yeah.
Okay.
Because here also they said respiration capable at week 25, and 25, if you correspond, it's like saccular phase. So respiration capable with surfactant will probably be saccular. That's what we decided on like Palm session also, I think. Let me double check.
Yeah, I think so. Because, I don't know why I have written canalicular, because I think if you see the first aid image, then it says that it starts at canalicular. So
Yeah,
think
that was a conflict we had when Palm we did. So yeah, it does say pneumocytes start developing at 20 and respiration capable at week 25, and that's the end of canalicular phase according to first aid. But in UWorld, it clearly says pneumocytes begin producing surfactants separately they put. So let me check what they asked. I think. And the real exam is not supposed to give this marginal unis vis quale questions. So hopefully they don't, but you never know. So ectopic, this is prophase meta one. The things, stages of lung development. Okay. Here they asked alveolar capillaries are dysmorphic. Pulmonary arterioles have narrow lumina with thick muscular walls. They are consistent with which of the following conditions? So thick muscular walls and few dilated or alveoli with decreased septation. So the answer was bronchopulmonary dysplasia or chronic lungs. So the other choices will be easy to rule out, I think. Pulmonary alveolar, so cystic fibrosis, no, there'll be mucus plugs. Neonatal infections, congenital cystic adenomatoid. So objective here was bronchopulmonary dysplasia is a common in premature infants due to arrest of fetal lung development in the saccular stage. Histopath examination will show impaired alveolarization, that is dilated alveoli, with decreased septation. Abnormal vasculogenesis, that is dysmorphic alveolar capillaries. PAP was lots of surfactant accumulation within the alveoli due to impaired clearance by alveolar macrophages. So that's the opposite spectrum. Okay, so yeah, here they said BPD's primary characteristic disrupted fetal lung development at early saccular. During this stage, which begins at 26 and extends until birth, terminal sacs are formed and undergo septation, increasing the surface area for gas exchange. This period is also critical for development and growth of capillary network within the septa. Characteristic histopath for BPD in this case is few dilated alveoli, poor septation due to disrupted alveolization, dysmorphic alveolar capillaries. Okay, then next, what else did they say in this context? Fetal lung maturity, phosphatidylcholine, which is also known as lecithin, should be higher than sphingomyelin. Yeah, I think that's the only question. Week 4, teratogenicity. Okay, yeah. Neural tube defect. Okay.
Thank you so much. Thank you.
You're welcome. Yeah, I think that's the only question in this context. Okay, cool. So yes, they asked about bronchopulmonary dysplasia. So we have to think of saccular phase. So saccular is responsible for terminal sacs. And if it's, yeah, I think I should make a note. If it's BPD, bronchopulmonary dysplasia, we have to think of saccular phase. But pneumocystis develop at 20 weeks, respiration capable at 25 week 25. So next we have choanal atresia. 680. Choanal atresia. What is choanal atresia? This is the blockage of the posterior nasal opening, often associated with bony abnormalities of the midface. Most often unilateral. When bilateral represents an emergency, and presents with upper airway obstruction, noisy breathing, and of cyanosis that worsens during feeding and improves with crying. Diagnosed by failure to pass the nasopharyngeal tube and confirmed with the CT scan. So what is this? Choanal is that opening, right? So it's blockage of the posterior nasal opening associated with bony abnormalities of the midface, most often unilateral. If it's bilateral, then it's an emergency and presents with upper airway obstruction and noisy breathing, cyanosis, upper airway obstruction, noisy breathing, cyanosis that worsens with feeding and improves with crying. Often part of multiple malformation syndromes such as CHARGE syndrome. What is CHARGE? Coloboma of the eye. Heart defects, atresia of choanae, restricted growth and development, genitourinary defects, and ear defects. Okay. So that's choanal atresia. Next, we have lung malformations. We have pulmonary.
Sorry. Once you shared coloboma of the eye, so in coloboma of the eye, there is an iris hole in the iris.
Yeah, like a keyhole, it will be there, like an opening in the iris, like this. It will be. This is the iris, but it will have an opening, like a black. I think someone shared in the group recently. Coloboma of eye, yeah. So that's associated with this CHARGE syndrome. So this coloboma and the choanal atresia may occur together. That's what they're saying. Okay. So
Yeah,
you're welcome. Let me see real quick. Yeah. So this is actually an NBME. It came up, I think, somewhere. We gave it in words, keyhole like opening in the eye, something in the iris. So that's the coloboma in the real eye.
interesting.
Defect in the iris of the eye in comparison is a black notch of varying depth at the edge of the pupil, giving the pupil an irregular shape. May be associated with hereditary conditions, trauma to the eye, or surgery. Sorry, you were saying?
Interesting.
Yeah. Yes. So next is lung malformations. We have pulmonary hypoplasia, bronchogenic cysts. So pulmonary hypoplasia, poorly developed bronchial tree with abnormal histology associated with congenital diaphragmatic hernia, which is usually left-sided, and bilateral renal agenesis, which is Potter sequence. So one more time, what is pulmonary hypoplasia? Poorly developed bronchial tree with abnormal histology associated with congenital diaphragmatic hernia, which is left-sided, and bilateral renal agenesis because of Potter sequence. So this we saw triggering event is oligoramnions. But then we have bronchogenic cysts. These are caused by abnormal budding of the foregut and dilation of the terminal or large bronchi. Abnormal budding of the foregut. So this is to do with bronchial tree and abnormal histology. Here it is abnormal budding of the foregut and dilation of terminal or large bronchi. Discrete, round, sharply defined fluid-filled densities on chest X-ray, which are air-filled if infected, generally asymptomatic but can drain poorly, causing airway compression, recurrent respiratory infections. Okay, so one more time, lung malformations, two types, two main things, pulmonary hypoplasia, bronchogenic cysts. What is pulmonary hypoplasia? Poorly developed bronchial tree with abnormal histology associated with congenital diaphragmatic hernia, usually left-sided, bilateral renal agenesis or Potter sequence. Then we have bronchogenic cysts, which is caused by abnormal budding of the foregut and dilation of terminal or large bronchi. Okay, then
What does it mean by abnormal budding of the foregut?
I think when foregut, if you could like do embryology, then foregut divides into structures of the upper respiratory, and then foregut is what gives rise to the upper GI tract. So this is supposed to bud properly, but something doesn't happen, so it becomes a bronchogenic cyst. Foregut, midgut, hindgut, and then this endoderm, mesoderm, all those, when it's developing, there's some problem. Exactly, I don't know, but it's vaguely. So it's caused by abnormal budding of the foregut and dilation of the terminal or large bronchi. So yeah, abnormal budding. So what happens is there's a dilation as well as dilation of the terminal or large bronchi. Discrete, round, sharply defined fluid-filled densities on chest X-rays. So the air-filled if infected, generally asymptomatic but can drain poorly. So there's airway compression and recurrent respiratory infections. So these are the main presentations: airway compression and recurrent respiratory infections because of abnormal budding and dilation of the terminal or large bronchi. Terminal bronchi should be fluffy and proper, so they'll be large, so they're abnormal. Okay. Then we have club cells. What are club cells? These are non-ciliated, low columnar cuboidal with secretory granules. Where are they located? In the bronchioles. And what do? They degrade toxins via the cytochrome P450. They secrete the component of surfactant in their progenitor cells for club cells and ciliated cells. Yeah, these are important. So what are club cells? Non-ciliated, low columnar or cuboidal with secretory granules, located in the bronchioles and degrade toxins via cytochrome P450. They secrete a component of surfactant and their progenitor for club cells and ciliated cells. So they're doing three things: degrade toxin, number one; secrete component of surfactant, number two; number three, progenitor cells for two things: club cells themselves and ciliated cells. Yeah, they themselves are non-ciliated, but they are the progenitor for ciliated cells. Okay. Then other cells, alveolar cell types, we have type 1 pneumocytes and type 2 pneumocytes. These are squamous. Type 1 pneumocytes is squamous, and they form the alveolar surfaces, thinly line the alveoli, and they're optimal for thinly line the alveoli for optimal gas exchange. Then we have something called the pores of cone. This, I think, is a UL question. So they are anatomical communications between alveoli that allow for passing of air, fluid, phagocytes, and bacteria, especially bacteria and pneumonia. Where these pores of cone are anatomical communications between the alveoli that allow for passing of air, fluid, phagocytes, and bacteria. Then type 2 pneumocytes, these are cuboidal and clustered. Two functions. Number one, they serve as stem cell precursors for two cell types, which is type 1 and type 2 pneumocytes, and they proliferate during lung damage. Number two, they secrete surfactant. From lamella bodies, arrowheads in B. Okay, here. These are all lamella bodies. Okay, application of law of Laplace in alveoli. Alveoli have a tendency to increase, alveoli have increased tendency to collapse on expiration as the radius decreases. Alveoli have an increased tendency to collapse on expiration as the radius goes down. Okay, law of Laplace is how much you stretch, that much it will come back or bounce back. Here it is. Increased tendency to collapse on expiration as the radius decreases. Yeah. So if we imagine an alveoli, as the radius decreases, there's more tendency to collapse to the center. So that's the law of Laplace. So on expiration, as they get smaller, there's more tendency to just collapse. Okay, here we have important things: surfactant from type 2 pneumocytes. What do? They decrease alveolar surface tension, they decrease alveolar lung collapse, and they decrease lung recoil and increase compliance. So one more time, they decrease alveolar surface tension. By decreasing the surface tension, they decrease the alveolar collapse and decrease lung recoil. Thereby, they increase the compliance of the alveoli in the lung. So they're composed of multiple lecithins, predominantly DPPC, which is dipalmitoyl phosphatidylcholine. Synthesis begins at 20 weeks of gestation and achieves mature levels at 35 weeks of gestation. Glucocorticoids important for fetal surfactant synthesis and lung development. Is glucocorticoids are important for fetal surfactant synthesis and lung development. Collapsing pressure equals 2 times the surface tension divided by radius. Collapsing pressure is 2 into surface tension divided by radius. I think this comes up in some question. So then the other cell type is alveolar macrophages. What are these? These are responsible for phagocytosing foreign materials, and they release cytokines and alveolar proteases. So they phagocytose foreign materials and release cytokines and alveolar proteases. I think this comes up later, right? Up to where, yeah, okay, we're going to see it. Okay, then hemosiderin-laden macrophages may be found, which are in the case of pulmonary edema and alveolar hemorrhages. So hemosiderin-laden alveolar macrophages in pulmonary edema and alveolar hemorrhage. So what are we seeing? Type 1 pneumocytes, which are lining the cavities, and type 2 pneumocytes are responsible for two things. One is stem cell for type 1 and type 2 and proliferating lung damage. Second thing they do is secrete surfactant. So again, graphic representation, type 1 pneumocytes are the blue cells, which line the alveoli. Then we have the type 2 pneumocyte, which produces surfactant and a stem cell precursor. Number 3 is the alveolar macrophages, responsible for phagocytosing foreign materials, and it also releases cytokines and alveolar proteases. And then the capillaries. And then here, they're pointing towards the lamellar bodies, which contain the surfactant. Okay.
And there's a question regarding lamellar bodies in the world, right?
Yeah. Yeah, they
What
use
was the specific thing for that?
I think what they asked was, what did they ask? Let me see.
The spores of corn is
Where are they
also
stored, I
question.
think. Sorry?
Yeah, where they stored, I think.
Yeah, lamellar bodies.
And spores of corn is also a question, right?
Yeah. So here, this is not related. Yeah, here. So analysis of several large cuboid alveolar cells under electron microscopy reveals decreased number of granules containing parallel stacks of membrane lamellae. They're describing decreased number of lamellar bodies. Decreased number of granules containing parallel stacks of membrane lamellae. Which of the following pathologic processes most likely associated? Increased alveolar tendency to collapse. So yeah, this we've seen. So lamellar type 2 pneumocytes store and release surfactant and decrease alveolar surface tension and facilitate lung expansion. Low count means reflects surfactant deficiency and lung immaturity, as in NRDS, which results in alveolar collapse and diffuse atelectasis. So 82, which are the stem cells, will also produce the type 2 pneumocytes, which produce the surfactant. And then they are packaged into lamellar bodies. And then this composed of tubular myelin. And then we have the alveolar macrophage on the side. And okay, this is recycled. Zoom in. We're seeing high surface tension, alveolar collapse. Low surface tension, alveolar expansion. So here there's increased surfactant. What are they showing here? Now you explained to me this one time, but I forget. So as the surfactant goes down, there is lower surface tension. And no, doesn't make sense. High surface tension, alveolar collapse. Yeah, actually, yeah. High surface tension, alveolar collapse. Low surface tension, alveolar expansion. So this low surface tension is produced because of the surfactant's ability. So here there's high surface tension and alveolar collapse, tendency to collapse. So they will absorb more of the surfactant. I think that's what they're showing. And as they go down, here there's less surface tension. So they won't absorb the thing as much. So then these are recycled, packed again, multivesicular, and then they form more and more lamellar bodies when needed. Okay, normal type 2 pneumocytes use lamellar bodies to store surfactant, a substance composed of proteins and phospholipids that decreases alveolar surface tension and facilitates lung expansion during respiration. This lipoprotein complex is released from the lamellar bodies by exocytosis into the alveolar space, where the lamellar contents unravel into structured array called tubular myelin. This lattice network absorbs to the air-liquid interface of the alveoli and spreads along the alveolar lining, forming surfactant film. As the film degrades, surfactant is recycled back to type 2 pneumocytes by endocytosis for reprocessing. Surfactant and low number of lamellar bodies in the fetus during the surfactant and number of lamellar bodies in the fetus rise during late second and third trimesters. Therefore, low count means surfactant deficiency, lung immaturity, which occurs in premature infants with NRDS. In this condition, alveolar surface tension increases and alveoli collapse. Diffuse atelectasis can lead to respiratory failure within minutes to hours after birth and in severe cases. Okay. All right, cool. So then next topic is NRDS. Here we have a surfactant deficiency, increased surface tension leads to alveolar collapse. There's classic buzzword, ground glass appearance of the lung fields as seen in this. Okay. So NRDS, there's a surfactant deficiency and increased surface tension leading to alveolar collapse and ground glass appearance of lung fields. Risk factors, what are they? We have prematurity, diabetes during pregnancy due to increased fetal insulin, C-section delivery, decreased release of fetal glucocorticoids. C-section delivery, there's decreased release of fetal glucocorticoids and less stressful than vaginal delivery. Yeah, less stressful for the baby than vaginal delivery, so it's not maturing okay as much, not producing as much surfactant. Okay, so treatment is maternal glucocorticoids before birth and exogenous surfactant for the infant. Give maternal glucocorticoids before birth and exogenous surfactant for infant. We have the therapeutic supplemental oxygen can result in RIB, so retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. So we have a question for each of this. So in association NRDS, retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. So we'll see those later. So this screening test for fetal lung maturity, there should be LS ratio in amniotic fluid more than 2 is healthy. Less than 1.5 is predictive of NRDS. So this is a lecithin sphingomyelin ratios in the amniotic fluid, which is a screening test for fetal lung maturity. The other thing is the foam stability index and a surfactant albumin ratio. So number 1 is lecithin sphingomyelin ratio. Number 2 is the foam stability index. Number 3 is surfactant to albumin ratio. Persistently low tension increases the risk of SBA. Persistently low oxygen tension increases the risk of PDA, sorry. Persistently low oxygen tension will increase the risk of PDA. So what are we seeing here? The ratio for lecithin is lower, then peaks start rising around 25 weeks and peaks at around 35 and plateaus around 38, around 40. Sphingomyelin is higher than lecithin initially, but it starts declining. The ratio, the net effect is initially it's low, but gradually increases and then starts peaking. So if the ratio, there's mature L over S, at risk if it's L over S age. Gestational age against concentration. So if it's mature lecithin concentration unless L or S. So this, if it's after more than 35, it gets higher. So concentration is around 3, 4, lecithin, sphingomyelin is lower. Okay. So according to that question, we just need to know that what happens. So here they ask, what will show amniotic constitution of two substances, the amniotic fluid of pregnant women are graphed below. Two curves most likely corresponded to which are the following. So one was lecithin, also known as phosphatidylcholine, and two was sphingomyelin. It needs to be more than 2 for lung maturity. Then there are 3 assessments: lamella body count, lamella body count, lecithin sphingomyelin ratio, and phosphatidylglycerol. All should be high except, also high lamella count, LS ratio higher than 2, phosphatidylglycerol presence. Then we know it's an indicator of lung maturity. What do? This lamella body store, transport, and secrete surfactant increase more than 2 weeks, more than 20 weeks. This LS ratio, lipid components of surfactant, lecithin increases more than 30 weeks gestation. Phosphatidylglycerol, lipid component of surfactant increases more than 35. So the ratio increases 30, phosphatidylglycerol 35 weeks. Okay. You good with this page?
We just have to remember this, the lecithin to sphingomyelin ratio is greater than 2. Healthy, less than 1.5 predictive of NRDS. I think this foam stability index is fetal lung. Okay, just another index for the fetal lung maturity. And what is the surfactant albumin ratio? Is there any ratio for that also?
There's no number, but yeah, we're just comparing this surfactant to albumin. Surfactant will be like lecithin, right? So it's what do you call it? I would say like kind of a glycerol, fatty acid compared to the albumin.
Okay. I think these are the indices. Okay, thank you.
I said it means we are comparing the fatty acids in the body to the albumin, which is the protein component, right? So I think we're just doing the ratio to see if it's, I don't know exactly the normal thing, but that's just a screening test for lung maturity, they said. Let me check.
Okay. It's okay, Sarah. Sorry. Go ahead.
Thank you. Maybe it's mentioned here. But yeah, I've not seen any questions actually. Yeah, elevated ratio correlated with fetal lung maturity. 55 mg of surfactant per gram of albumin. So next we have the respiratory anatomy. Respiratory tree is divided into the conducting zone and the respiratory zone. So conducting zone consists of large airways, which consists of nose, pharynx, larynx, trachea, and bronchi. Airway resistance is highest in the large to medium size bronchi. This is a question, right? Resistance is highest in the large to medium size bronchi. So large airways consist of what? The nose, pharynx, larynx, trachea, and up to the bronchi. Airway resistance is highest in the large to medium sized bronchi. This is the question. Small airways consist of bronchioles that further divide into terminal bronchioles. There are large numbers in parallel, so least airway resistance. Highest resistance in large to medium, large numbers in parallel, which are bronchioles, least airway resistance. Bronchioles and terminal bronchioles, so there are large numbers in parallel. Okay, then what is the responsibility of the conducting zone is to warm, humidify, and filter the air, but does not participate in gas exchange. That's why it's just known as a conducting zone. And this is known as an anatomic dead space. Cartilage and goblet cells extend to the end of the terminal bronchi. This is a question. Cartilage and goblet cells extend to the end of the terminal bronchi. Then there's no more cartilage after that. Pseudostratified ciliated columnar cells primarily make up the epithelium of bronchus. Pseudociliated columnar epithelium make up the epithelium of the bronchus and extend up to the beginning of the terminal bronchioles again. Actually, all the way here. This is pseudostratified ciliated columnar cells. What's the lining? Pseudostratified ciliated columnar cells make up the epithelium of bronchus and extend to the beginning of the terminal bronchioles, then transition to cuboidal cells. Clear mucus and debris from the lungs is a mucus. They clear, yeah, okay. So conducting zone, so clears mucus and debris from the lungs. So they are also responsible for mucociliary escalator. Airway smooth muscle cells extend from the end of the terminal bronchiole and sparse beyond this point. So smooth muscle cells in the airway, smooth muscle cells extend at the end of until the end of the terminal bronchioles, after which they disappear again. Okay, next, what is the respiratory zone? This is consisting of the lung parenchyma, consists of respiratory bronchioles, alveolar ducts, and alveoli. So lung parenchyma composed of the respiratory bronchioles and consists of respiratory bronchioles, alveolar ducts, and alveoli itself. Participates in gas exchange. So that's why they are the respiratory zone. Mostly cuboidal cells in the respiratory bronchioles, then simple squamous cells up to the alveoli. So cuboidal, then simple. So here it is pseudostratified ciliated columnar, then they transition to cuboidal. Cuboidal majority, then cuboidal becomes simple squamous cells up to the alveoli. Cilia terminate in the respiratory bronchioles. So this is important. Cilia terminate where? In the respiratory bronchioles. Alveolar macrophages clear the debris and participate in immune response beyond this point. So this is, each thing is a question, and they usually ask in what levels. So we'll see from the image. So conducting zone is just conducting air, warming the air, humidifying the air, and just filtering the air, but it does not participate in gas exchange. So it's known as an anatomic dead space. And then there's also a question where if the patient is having like a connected to a vent, then that's lots of tubing. So that's increasing the anatomic dead space. Okay, so conducting zone is divided into trachea, bronchi, bronchioles. So up to the terminal bronchioles is the conducting zone. So here we are seeing goblet cells. So initially in the trachea and bronchi, we have the goblet cells and basal cells, ciliated, pseudostratified columnar epithelium. There is a smooth muscle. They said smooth muscle. Smooth muscle extends to the end of the terminal bronchioles. So terminal, and then after that it tapers and it stops. Okay, so pseudostratified columnar epithelium, ciliated cells, smooth muscle present, cartilage present. Cartilage ends where? The level of the terminal bronchi. Bronchi, actually, sorry. Cartilage and goblet cells extend to the end of the bronchi. So up to here mainly is the goblet cells and cartilage. After this, they are not supposed to be present. At bronchiole level, we have simple ciliated, so pseudostratified ciliated columna became simple ciliated columnar epithelium. There is smooth muscle here. Then terminal, here also we have few cuboidal cells and club cells. Simple ciliated columnar epithelium and smooth muscle present. Smooth muscle present, smooth muscle present, smooth muscle present. Then when they transition to the respiratory zone, we have respiratory bronchioles, the alveolar ducts, and the alveolar sacs. So here, what's the lining? We have simple cuboidal and squamous epithelium. Smooth muscle is very sparse. Cuboidal cells, club cells, and squamous cells are same. Alveolar sacs, single lining with the type 1 pneumocyte, type 2 pneumocyte, alveolar macrophages, and the capillaries. So that is the respiratory tree. Okay, we good?
Yeah, so just a questions wise, Saira. Sorry, my voice is not echo, right? Are you fine?
Yeah, I can hear you.
So airway resistance is highest, you said, in large to medium-sized bronchi, right? In the upper level.
Correct.
These airway resistance is least in the terminal bronchioles because these are parallel, right?
Correct. Exactly.
Okay. And the other anatomical dead space, you said what will increase the anatomical dead space?
Say again, what's the question? Anatomic dead space?
Yeah, you said now that I think ventilation or something like that.
Yeah, I said if the patient has a ventilator, they had a question, I think arrow question, and they had patient was having a ventilator. So it was a lot of tubing, right? So it increases the conducting zone and it increases the anatomic dead space. That was what they were checking.
Okay, increasing the anatomical dead space. Okay, and then I think cartilage and goblet cells. This is also a question. Cartilage and goblet cells extend to the end of the bronchi. Okay.
Yeah. They asked where do they disappear? So they're only present in the trachea and bronchi. Yeah.
Okay. And then there is also a question about this mucociliary escalator thing, right?
Correct. Yeah. They ask about where the cilia disappear, where the cartilage disappear, and up to which level, after which level will the macrophage be responsible for the protection of the airway.
Okay, so yeah, so airway smooth muscles extend to the end of the terminal bronchioles, and then they will be sparse beyond this point, right? Okay.
Yep.
Okay, I think, so cilia will continue at the level of the respiratory bronchioles, but I think no cilia beyond the respiratory bronchioles, right?
Exactly. Yep.
Okay.
And actually, what they mainly ask is what is responsible for protection beyond the terminal bronchiole? I think that was the question on your world. So we were supposed to pick the alveolar macrophages. Because even though cilia will be the choices, there's very less cilia at this level. So the main, I think the question the way they asked was the fine silica particles. Remember, silica will escape the cilia, something like that, and alveolar macrophages will be responsible.
I remember with mucociliary clearance and something with macrophages thing. Silica, yeah,
Yeah, 6-year-old boy playing in a dusty field, windy weather, inhales many small particles that become lodged in his terminal bronchioles. Which of the following respiratory components is most important in clearing these particles? So ciliated cells are the responsible ones at the level of the terminal bronchioles and beyond. Because at this point, very less cilia remain. So terminal bronchioles are covered by ciliated cuboid epithelium and club cells. Actually, no, I think I'm mixing it up. So terminal bronchioles are covered by ciliated cuboid epithelium and club cells, which help with mucociliary clearance in this region. So this dusty particles at the level of terminal bronchioles will be cleared by the cilia. Macrophages will be at particles that lodge distal to the terminal bronchioles dependent on phagocytosis by alveolar macrophages. They can destroy inhaled particles like bacteria by lysosomal degradation. Non-digestible material must be transported by macrophages to the pulmonary lymphatics or to the terminal bronchioles for clearance by the mucociliary system. So distal to the terminal bronchioles, so that's the cutoff. Up to the terminal bronchioles, it's the ciliated cells.
okay. Okay, thank you.
You're welcome. Up to terminal, I'm just making a note. Up to terminal bronchioles, it is the ciliated cells. Then after, so distal to terminal bronchioles is alveolar macrophages. And they had asked another question with the macrophages. Let me see. Yeah, in silicosis, internalized silica particles impair macrophage function. This is important. By disrupting phagocytosis and promoting apoptosis, increases the risk of bacterial infection, particularly MTB. And here, find carbon particles within the patient's respiratory bronchioles and alveolar ducts on biopsy. Which of the following mechanisms is most likely responsible? So here we are at the level of respiratory bronchioles and alveolar ducts. So we are here. So at this point, it's phagocytosis. So yeah, this should be our cutoff. Respiratory bronchioles and alveoli. So RA is the macrophages, RAM. So respiratory bronchioles, alveoli is for macrophages are responsible. Phagocytosis. Pneumoconiosis are diseases from inhaling fine dust particles that reach the respiratory bronchioles and alveoli. Particles that lodge in this region, normally cleared by alveolar macrophages. High particulate burden can cause excessive release of cytokines from macrophages, resulting in progressive pulmonary fibrosis. Okay. Okay, yeah. So that was our questions. Okay. So main thing to remember, up to terminal, who's responsible? Ciliated cells. After this, alveolar macrophages. Okay.
Yeah, thank you so much. And club cells and Clara cells are in the bronchioles level, right?
Yeah, club and Clara are up to the bronchial level. Yes.
And they start at the level of the club cells. Club and Clara cells are the same thing, right?
Oh yeah, actually, yeah. Club and Clara are the same, yeah. Yeah, you're right. You will cause it Clara, yes. Let me just pull up that image also. But yeah, it's not high yield, so we shouldn't worry about it. What were you actually saying? Club and Clara are?
And they start in the level of the bronchioles, right? And then they continue down to the terminal bronchioles and respiratory bronchioles.
So club or Clara will continue here also. Yeah, you're right. So they stop at this level, or they're not present in the alveolus. That makes sense, right? Here we only have a single lining. So up to that, we have the club cells. So here, not much, but yeah, club cells, bronchioles, terminal bronchioles, and respiratory bronchioles. So basically, all of the bronchioles have the club cell, also known as Clara cell. Yeah. That Clara cell comes in some pathology, though. So it is important. Anyway, okay, we'll see. So yeah, as you said, main points here, airway resistance highest where large to medium-sized bronchi. That's one. Then least airway resistance where terminal bronchioles. Why? Because they're in parallel. Anatomic dead space fact. Then cartilage and goblet cells up to where? Cartilage up to where was the question? So that's up to the bronchi only. So pseudo-stratified ciliary columnar cells are responsible for the mucociliary escalator. Smooth muscle cells are only up to the terminal bronchioles and then they become sparse. Respiratory zone is respiratory bronchioles and alveolar sacs. They participate in gas exchange. Cuboidal cells mostly in the respiratory alveoli. Cilia terminate in the respiratory bronchioles. Alveolar macrophages clear debris and participate in immune response after this level, after distal to the terminal bronchiole. Okay, so next we have lung anatomy further. This is high yield page. Right lung has 3 lobes, left has less lobes, and a lingula. Right has 3, left has less lobes and a lingula, homologue of the right middle lobe. Instead of a middle lobe, the left lung has a space occupied by the heart. Relation of the pulmonary artery to the bronchus at each lung hilum is described by RALS, which is right anterior, left superior. Relation of the pulmonary artery to the bronchus at each lung hilum is RALS. So the on the right side, the pulmonary artery is anterior to the bronchus, On the left side, the pulmonary artery is superior to the bronchus. It's not showed here, but okay. So RALS for the hilus. Hilus is where the trachea divides into the, no, that's the carina. What's the hilus? Isn't the hilus also the to where it splits? Let me check.
Where everything bronchus and all it enters into the lungs, that's the hilum, no?
Attachment side, yeah, you're right. Point at which various structures enter and exit the lung. So the point at which the bronchi is entering the lung, right?
Yep.
Okay, where it's entering. So on the right side is anterior, on the left side it is superior. So relation to the pulmonary artery with the bronchus. Bronchus over here is the yellow one, I'm thinking. On the right, it is anterior. On the left, it is superior. So it does make sense, right? Correct?
Yep.
Okay, thank you. Skills, match for visual memory. Okay. So yeah, the relation of the pulmonary artery, which is carrying deoxygenated blood. So that's why it's blue here. So to the bronchus at each lung hilum is described by, on the right side, the pulmonary artery is anterior. On the left side, it is superior. Okay. Carina is posterior to the ascending aorta. Carina is where it's splitting into the left and right bronchus. So that is posterior to the ascending aorta and anteromedial to the descending aorta, as seen in B. So here, carina is where the bronchi is splitting into two. So this is posterior to the ascending aorta and anteromedial to the descending aorta. The right lung, this is high yield. Right lung is more common site for inhaled foreign bodies because the right main stem bronchus is wider, more vertical, and shorter than the left. Right lung is more common site for inhaled foreign bodies because the right main stem bronchus is wider. It's more vertical, so it's aligned with the main trachea, and it's shorter than the left. So if you aspire a peanut while supine, it usually enters the superior segment of the right lower lobe, sul. Superior, in supine, superior segment of the right lower lobe. That was one part. We're coming to this in a sec. While lying on the right side, it usually enters the right upper lobe. When upright, it usually enters the right lower lobe. So either way, it's always going to be the right side. So the more in-depth was better with the UWorld image. When upright, it goes to the basilar segments, which is most dependent. In supine position, posterior segment of the upper lobe, pull, and superior segment of the lower lobe. Posterior upper lobe, superior lower lobe. So pull, sul. Superior lower lobe. Superior segment of lower lobe. This was a question on UWorld. Patient is supine, where does it go? Pull, sul. Posterior segment of upper lobe, superior segment of, the SU here stands for superior. So superior segment of lower lobe. So you can say PUL, SLL. So no confusion. Okay, that's dependent and foreign body. So yeah, here they said if when supine, which is lying down, it enters the superior segment of the right lower lobe. Also say the same. When lying on the right side, it enters the right upper lobe. When upright, it enters the right lower lobe, which makes sense, gravity. So then we have questions with the stab injuries and stuff. So this topography is important, and stab injuries, and also for pericardio or pleural centesis and stuff like that. So the topography of the lungs. So this is important even in NBME questions. 6, 8, and 10. So this is the lower border of the pleura. So the lungs and the visceral pleura versus the parietal pleura. Lung and the visceral pleura at the mid-clavicular line, the lower border is in the 6th rib. Mid-axillary line, which will be the 8th rib, and paravertebral, the 10th rib. Parietal pleura is 8, 10, and 12. 10th rib, right upper border, left lower border. But yeah, 6, 8, 10, 10, 8, 10, 12. That's what the main thing we need to know.
Sorry, 6th, 8th, 10th for the visceral pleura, right?
Lung and the visceral pleura, yeah. Lung and
for
visceral pleura is ekdam chipka hua to the lung, right? So that's
Yeah.
But
These are ये normal location है ना सायरा?
yeah, normal location, yes.
कि कहाँ पर ending होती है उसकी? Okay.
Mhm.
So mid-clavicular 6th, mid-axillary 8th, and paravertebral is 10th
Mhm.
for visceral, and parietal is mid-clavicular 8th, mid-axillary 10th, paravertebral 12th.
Yeah. Mhm. Yep. Then what else on this page? Yeah. So that's the anatomy. And I think I don't know if any of you all remember, there was a stab injury, and if it's close to the 6th rib, it injures the lingula. Close to the heart, but it didn't puncture the lung was a question. So it affected the lingula. And there's another question. If it's most anterior, I think most of the anterior surface of the heart is the, what is it? Left
Right
ventricle?
ventricle.
Right ventricle. Yeah. So
And
right ventricle.
parasternal then, right?
Parasternal, yeah, correct. That question had parasternal stab wound at the level of the 5th or 6th rib, something they said. And it punctured what? I think the answer was right ventricle, if I'm not wrong. There were 2 or 3 questions like that. So one was about the heart. And then another was they did the pleurocentesis. And if you go a little bit more deeper, there's a right liver lobe, and is at risk for puncture. That was a question. So yeah, lungs and the viscera. So in the mid clavicular, it'll be 6, mid axillary 8, and then PJ 10. 6, 8, 10 for the lower border of the lungs and the visceral pleura. But for the parietal pleura, it'll be 8. So this brownish colors ending in 8. Mid axillary will be 10. It's not shown here clearly, but yeah, 10, and then 12 on the paravertebral. So here 12 is ending. So we see that clearly. This should technically be 8, 10 in the mid axillary on the side, and then 12 on the back.
Yeah, Saira, I think one question was that lung was injured, right?
Yeah. One was heart, one was lung question, one was this liver lobe ka question. Let me see.
About the paracentesis में था ना कि like right lobe of the lung is got damaged, right? Something like that. Or left lobe of the lung liver get damaged.
Right liver.
एक तो ये anterior most part था. That's your right for right anterior, right ventricle के लिए. और एक यहाँ पर what was that question? It para.
Mid clavicular line wala hai kya? Amna, the medial to the mid clavicular line it injured to the lung.
I think so, yeah.
Was it this question? ED after being involved in a fight nearby bar, respiratory rate is 28, BP 8860, heart rate 114. Penetrating right-sided stab wound along the upper surface. Oh no, this is upper surface of clavicle. Between the lateral border of the sternum and mid-clavicular line. What will be structure injured here? Pleura. Right-sided stab wound along the upper surface of clavicle between the lateral border of the sternum and mid-clavicular line. So यहाँ पे apex is there, so pleura is damaged.
I think यही नहीं था.
Yeah, I think so. One was a pleura, then one was the right anterior thing, and the other one is the pericardiocentesis. ये वाला ना, stab injury. How do they describe it? Examination shows a deep penetrating wound in the fourth intercostal space along the left sternal border. Fourth space, left sternal border. What is injured? Right ventricle. Left parasternal impalement wound.
So left ventricle पे कब ऐसा क्या होगा जो left ventricle would be the answer?
Stab wounds angle slightly medially in the fourth intercostal space at the mid-clavicular line could strike the left ventricle, but only after passing through the bulk of the left lung. So it's very unlikely, na? Pura lung pierce karte jate, then it has to go to the left ventricle. So it's unlikely. Or if they give the scenario, then the patient will be really in a bad state.
So left ventricle is उसके lung के पीछे छुपा हुआ है, right?
Correct, exactly. That's a nice way to put it. Left ventricle is छुपा हुआ है, hiding behind the left lung. Right ventricle is anterior most, so that gets injured.
So whether it is the parasternal, right parasternal or left parasternal, the wall which the chamber would get stabbed would be the right ventricle, right?
Correct, yeah. And then left atrium, they usually talk about the
Posterior side pain.
transthoracic this thing, right? Transthoracic transesophageal, sorry, yeah. Transesophageal echo when they do that wala question for left atrium.
MS scale, you know.
Yeah. For which one? Sorry, yeah. What did you say in the end?
Mitral stenosis.
Mitral stenosis. Yeah, okay. मेरे दिमाग में multiple sclerosis. I'm like, what? This also we saw Pringle, yes, we saw in GIT. If it's occluded and there still continues to hemorrhage, then the source is inferior vena cava. Because we are compressing the hepatic structures, common bile duct, hepatic artery, and the portal vein. So that was the Pringle maneuver. Like you're holding a Pringles chips. Okay, what else on this page? Karina was a question actually. It came up on some NBME. I remember Neelu and I were talking about Karina.
Yeah. So carina is posterior to ascending aorta and anterior
Medially and
anteromedial to the descending aorta.
yep.
And you said that when the patient is supine, so either it goes to the posterior segment of the upper lobe or superior segment of the lower lobe, right?
Correct. Yep.
So superior segment of the lower lobe. Okay. But if he's lying on the right side, then it goes to the upper right lobe, right?
Yeah, upper right. They didn't go in detail. They just said upper right lobe. Oh, pull wala part. Posterior upper lobe. Right?
While lying on the right side, usually enters the right upper lobe. Okay. Thank you.
And then when upright goes to the lower lobe, yes. Okay. Thank you. So next we have diaphragm structures. Structures perforating the diaphragm at T8, IVC phrenic. At T10, esophagus vagus. So C10, cranial nerve 10 has two trunks. So T10, CN10. Okay, 2, दोनों के दो trunks. T12, aorta, red, white, and blue. So at aorta has a red, which is aorta, thoracic duct, which is white, azygous vein, which is blue. At T12, it's the red, white, and blue. Diaphragm is innervated by C3 to 5, which is phrenic, and whole prone, middle lobe, and lingula. Oh, nice. The patient is prone, which means they're sleeping on their stomach. Then it's the middle lobe and lingula. Oh, really? So then it goes to the left side also. Whole prone, while prone, it is middle lobe. On the left or the right? Sorry. But lingula is on the left, so yes, left lobe. Thank you so much. And okay, so next, yeah, we were at aorta. It was white structure, red structure, white structure, and the blue structure. So red is the aorta, thoracic duct is white, azygous vein is blue. At T12, T12, there is a red, white, and blue. Diaphragm is innervated by C3 to C5, which is phrenic. Pain from the diaphragm irritation can be referred to shoulder. That's a question. So that's C5, and the trapezius ridge, C3, C4. Phrenic nerve injury causes elevation of the ipsilateral hemidiaphragm. Yeah, that's usually described in the question stem. So yeah, at one more time, diaphragm innervated by C3 to 5 phrenic. Pain from the pain from the diaphragm irritation can be referred to the shoulder, so C5, and the trapezius ridge, C3, C4. Trapezius ridge, okay. Phrenic nerve injury causes elevation of the ipsilateral hemidiaphragm on X-ray. And I8, so the number of letters is the T level. So T8 is, so I8, 10 eggs at 12 is the mnemonic. I8, so IVC at T8, 10 eggs, so at T10 is esophagus, at 12, at is aortic hiatus at T12. C3, 4, 5 keeps the diaphragm alive. Other bifurcations are CC, excuse me, common carotid bifurcates at C4, trachea bifurcates at T4, and abdominal aorta bifurcates at L4. So C4, T4, L4 for common carotid, trachea, and aorta, abdominal aorta. So image, you're seeing the three structures. So at T12 is the aorta, which is a red structure, thoracic duct, not pictured here, and the azygous vein, not pictured here. I8 is for T8 is IVC, 10X is 10 for esophagus, at 12 is for the aorta at the 12, aortic hiatus. So this we're looking from inferior view. So vertebra and inferior view. Ribs are here, okay. Foot and patient, we're looking from the bottom. And the central tendon is there, okay. Yep. So structures perforating the diaphragm are at T8, IVC and right phrenic. At T10, esophagus and vagus. At T12 is aorta, thoracic duct, and azygous vein. So this is also important. At T8, two things, IVC and phrenic, right phrenic. At T10, esophagus and vagus. Cranial nerve 10 has two trunks, okay. At T12 is the three things, red, white, and blue structures. Diaphragm is innervated by C3 to 5 phrenic nerve. Pain from the diaphragm irritation can be referred to the shoulder with C5, and trapezius ridge, C3-4. Phrenic nerve injury causes elevation of the ipsilateral hemidiaphragm on X-ray. So yeah, I8, T10s at 12, okay. C3-4-5 keeps the diaphragm alive. Other bifurcations, common carotid bifurcates at C4, trachea bifurcates at T4, and abdominal aorta bifurcates at L4. And this is showing the carina, which we saw, and yeah. Roughly the right upper lobe is there, right middle lobe, right lower lobe, left upper lobe, and left lower lobe. Okay, it's done. Okay, next we have respiratory physiology. So lung volumes and capacities. Note, a capacity is a sum of more than equal to two physiologic volumes. A capacity is a sum of more than two physiologic volumes. There are 4 volumes and 4 capacities. Capacity is always a sum, okay. So we have tidal volume, inspiratory reserve volume, IRV, ERV, residual volume. So 1, 2, 3, 4 volumes. 4 capacities, inspiratory capacity, FRC, vital capacity, total lung, actually 1, 2, 3, 4, yeah. So first, what is tidal volume? The air that moves into the lung with each quiet inspiration, 6 to 8 ml per kg, typically 500 ml. So memory jog, what was Kussmaul's breathing? What happens to the tidal volume?
Rapid deep, right?
Correct. Nice. Rapid yet deep breathing. But tidal volume is changing or not changing?
Tidal volume, not.
No change, yeah. Tidal volume doesn't change, only the respiratory rate changes, I think. No, no, I was the other way around, sorry. Tidal volume will change. No. It's rapid, so respiratory rate changes and tidal volume doesn't change. Correct?
Is it mentioned over there? A small
Yeah.
respiration?
Yeah, it was when we did it. This is Kussmaul's sign, which is the drop in the paradoxical drop, increase in JVB, sorry, on inspiration. That's Kussmaul's sign. Kussmaul breathing. I remember we spoke about it. Yeah, respiration is rapid and deep breathing. We also saw, I don't know if it was your question.
Maybe you're talking about workup breathing. Is it?
No, it mentioned two things, the tidal volume and the respiratory rate. One thing doesn't change, one thing changes.
I think you are talking about the pregnancy changes, I think we have seen yesterday.
Maybe.
Tidal volume increases, but respiratory rate, I think, doesn't change.
Yeah, you're right.
So small is in DK, right? Wahi wali
Yeah.
breathing.
Correct. Kussmaul was DK, and there we said it's rapid yet deep. That was Kussmaul. And yeah, the one I confused it was normal pregnancy. Sorry about that. There is where we said rate increases and tidal volume doesn't, isn't it?
No, rate doesn't. Oh, I don't know.
I think tidal volume increases, but respiratory rate remains same in pregnancy.
Yeah, that's right. That sounds right. Tidal volume doesn't change. Respiratory rate changes. What's the key buzzword in that page? Okay. Yeah, here is where we saw. Sorry about the mix-up. So the correct thing is respiratory. Yeah, VT is increasing, unchanged respiratory rate. So tidal volume is increasing, meaning the amount they breathe in and out in a minute is increased, but respiratory rate is unchanged. And Kussmaul was just about the rapid yet deep breathing. Yes. Thank you. Thank you for correcting me. So going back, we were doing the tidal volume. So here with pregnancy, tidal volume will go up. Okay. So back to this here, tidal volume. What is tidal volume? The air that moves into the lung with each quiet inspiration. So this tidal volume is going up in pregnancy. 6 to 8 ml per kg, typically approximately 500 with quiet inspiration. Okay. Inspiratory reserve volume. So yeah, here we see quiet respiration, inspiration, expiration, the amount that air that moves into the lung is typically approximately 500 ml or 6 to 8 ml per kg. Then we have inspiratory reserve. The reserves will both usually be the words maximal. Air that can still be breathed in after normal inspiration, or they say on maximal inspiration. So air that can still be breathed in after normal inspiration or on maximal inspiration. That's inspiratory reserve, IRV. Then expiratory reserve volume is the air that can still be breathed out after normal expiration or on maximal expiration. And then residual volume is the air in the lung after maximal, remaining back in the lung after the maximal expiration. RV and any lung capacity that includes RV cannot be measured by spirometry. Yeah, it's what is remaining in the lungs, so we cannot measure it. So it makes sense. It's usually calculated. RV and any RV that includes RV cannot be measured by spirometry. And then Faisal had a mnemonic, right? He mentioned FRE was for F. What was it? Anyone remembers? Is he here? No, he's not. Think if it was this one, F equals R plus E. Okay, so we'll get to it. Next, we have capacities. These are inspiratory capacity, vital capacity, and TLC. So inspiratory capacity is IRV plus the VT. The VT plus the inspiratory reserve volume is the inspiratory capacity. Then air that can be breathed in after normal exhalation. Then functional residual capacity is residual volume plus the expiratory reserve volume. So this was free mnemonic. Functional residual is whatever is functionally residuing and getting left behind in the lung. So RV plus ERV. Volume of gas in lungs after normal expiration. Outward pulling of the chest wall is balanced with the inward collapsing force of the lungs. The outward pulling force of the chest wall is balanced with the inward collapsing force of the lungs. Then what is vital capacity? This is inspiratory reserve volume plus the VT plus the ERV. So this full one line, IRV plus VT plus the ERV is the vital capacity, this full thing. Then TLC includes the residual as well. IRV plus VT plus ERV plus RV. Or in other words, this is vital capacity plus the residual volume. This including this bit, if you add the RV, then that's total lung capacity. Okay. Then, so what is the vital capacity? Maximum volume of gas that can be expired after a maximal expiration. Vital capacity is the IRV plus the VT plus the ERV. And this is the maximum volume of gas that can be expired after maximal inspiration. So we are at maximal inspiration point, and what can be expired after that is the vital capacity. Then total lung capacity, everything. So volume of gas present in lungs after a maximal inspiration. Okay, then, so yeah, lung capacities, we said 4. IC is inspiratory capacity, which is the inspiratory reserve volume plus the vital capacity. So inspiratory capacity is tidal volume plus the inspiratory reserve volume, which is corresponding to this. Then functional residual is what? Residual volume plus the expiratory reserve volume. So it's corresponding to this. Then vital capacity is the sum of inspiratory reserve, tidal volume, and the expiratory reserve. That's vital capacity. Total lung is everything. Okay. And TLC is not changed in. Tender loving care is not changed with. Elderly patients, right? That was a mnemonic. Tender loving care, total lung capacity is not changed, although the vital capacity might change. Okay, we'll get to it later. So changes in aging. All right, so next we have work of breathing. This refers to the energy expended or oxygen consumed by respiratory muscles to produce the ventilation needed to meet the body's metabolic demand. What is work of breathing? It refers to the energy expended or the oxygen consumed by the respiratory muscles to produce the ventilation needed to meet the body's metabolic demand. It comprises the work needed to overcome both the elastic recoil and the airway resistance. So what is work of breathing? It refers to the energy that needs to be spent or energy expended or oxygen consumed by the respiratory muscles to produce the ventilation needed to meet the body's metabolic demand. It includes what? The work needed to overcome the elastic recoil and the airways resistance. That is, work equals force into distance. Force it needs to overcome, and distance, airway resistance, so the amount of distance it needs to cover, which is mathematically it's pressure into volume. So work equals force into distance equals pressure into volume. It's minimized by, this comes up in questions. How do you minimize the work of breathing? By optimizing the respiratory rate and tidal volume. So in vent settings, you minimize the work of breathing by optimizing the respiratory rate and tidal volume. The work of breathing is increased in restrictive diseases. Makes sense because the increased work is needed to overcome the elastic recoil achieved with, how do they manage? By increasing the respiratory rate and decreasing the tidal volume. So shallow and fast breathing. So restrictive lung diseases. So work of breathing is increased. Why? Because they have more work to do to overcome the elastic recoil. And how do we achieve it? How do they manage the increased work of breathing? By increasing respiratory rate and decreasing tidal volume. Then in obstructive lung diseases, so it's increased here also, but the reason is here increased work to overcome airway resistance. Obstructive, the airways are resistant. That's the main problem. So how do they manage? Decreasing the respiratory rate and increasing the tidal volume. So they breathe tidal volume, if normally is this much, their tidal volume, they'll take in more air in and out. Slow and deep. So decrease respiratory rate and increase tidal volume. Okay, that's work of breathing. Next, we
have to remember, Saira, for this work of breathing.
Formula or like restrictive disease, obstructive disease? What did we say? Increase
this whole thing.
Increase in restrictive diseases, RR. So R goes up. जो भी उसमें है, R thing, that's the R. So R goes up in R, respiratory rate, restrictive diseases. I don't know if this helps, but so just if you focus on the R, the letter R, restrictive. So what will go up? Respiratory rate. The opposite for obstructive. Don't know. I don't know. I just think about it. Like restrictive is always something is restricting the breathing, right? So you cannot breathe enough.
Elastic recoil problem, right? In
Exactly.
restrictive.
Yeah.
Okay, so increased work to overcome. Increased work to overcome elastic recoil by increasing the respiratory rate, but decreasing the tidal volume. Tidal volume is basically air that moves into the lung with each quiet inspiration.
Exactly.
So although they are respiring more, but their tidal volume is decreased.
Exactly.
Because less air then goes into the. If tidal volume is decreased, then less air goes into the lungs, right?
Correct. Exactly. Yep. So दोनों में काम ज़्यादा बढ़ गया. Like you have to breathe hard, correct? Restrictive में क्या होता है? They breathe less per breath, but they breathe more frequently. So respiratory rate is increased. So the tidal volume is lesser. If this is a normal tidal volume, here they will be breathing fast but shallow. That's for restrictive. Obstructive, what's the problem again? The airway problem, right? For example, like COPD, obstruction is mainly the airway problem. So here also work is increased. But here they will be like breathless, right? So if when breathless, they'll be like asthmatic patients, they'll be like breathing. Oh my God. They will be breathing higher and less respiratory rate. Sorry, Nilu, you were saying something?
Sarah, I think as think of pink puffer in obstructive. The respiratory rate is not increased, like but deep breathing. They're just having like deep breaths, and respiratory rate is decreased in pink buffer. They're holding their breath.
Oh yeah, that's it only a good one. So in obstructive diseases, basically, increased work to overcome airway resistance, which is achieved if we are pink puffers, so they are pursed their lips. So respiratory rate will be decreased, but the tidal volume will be increased. But in restrictive, it's the work of breathing increased because it's a rapid shallow breathing.
Yeah.
Respiratory rate will be increased, but the VT will be down. Okay, and what is this? Work is equals to force into distance. Force into distance, which is equals to pressure into volume. These formulas are important?
No, I don't think so. I'm not seeing a question asking that. It's more for understanding. I don't think they'll ask directly.
Yeah. Okay. Thank you. Thank you, Neelu. Thank you so much.
Thank you. Thank you, guys. So next we have this formula is important though. determination of physiologic dead space, VD equals VT into Paco Pico by Paco, we used to say, right? So VD equals, or dead space equals the tidal volume into Paco minus Pico divided by Paco. Paco, it has A, that always comes first because I always confuse that. A comes first, then E divided by Paco again. So what is VD? This is physiologic dead space equals the anatomic dead space, which is not participating in the respiration, plus the alveolar dead space. So that is known as the physiologic dead space. Physiologic dead space, VD, which is the physiologic dead space, is the anatomic plus the alveolar dead space. Apex of healthy lung is the largest contributor of alveolar dead space. VD equals volume of inspired air that does not take part in gas exchange. PACO 2 is arterial PCO2, arterial carbon dioxide partial pressure. PICO 2 is expired air, PCO2. Physiologic dead space approximately equivalent to anatomic dead space in normal lungs. Physiologic is approximately equal to the anatomic dead space in normal lungs, and everything, like most of the alveoli are participating. It may be greater than anatomic dead space in lung diseases. So physiologic dead space is greater than anatomic dead space in lung diseases with ventilation perfusion mismatch. So this was the image on UWorld. We have anatomic dead space is all the gray area. So it's the conducting cis pathway, which is not participating. So anatomical dead space is by nose, mouth, pharynx, trachea, and bronchi. Even the bronchi, actually. That's the anatomic portion. Physiologic equals anatomic plus alveolar. Anatomic is all this, conducting zones. Alveolar dead space is alveoli that are ventilated, which means they're getting oxygen, but they're not getting blood supply. So they're not perfused. Versus so that's more in the upper lung. Compared to the lower lung, we have here we have high perfusion because of gravity, more blood coming there, and oxygenation. So it's matching. So alveolar dead space is more in the upper lobes. But don't confuse this with the concentration of the alveoli because that has slinking effect. Remember, that always gets me in questions. So we'll get to it in a few, but this is the dead space. Physiologic equals anatomic plus alveolar dead space. Alveolar dead space is highest in the upper lobe. What are these? These are ventilated but not perfused alveoli. One more time, what is VD? VT into PACO 2 minus PICO 2 divided by PACO 2. Okay. We're good with this page? Okay, I'm zooming yes. So next we have ventilation, physiology still, most of physiology concepts here. Okay. Let's do this, at least physio to finish today. Okay. Okay, here's where we are. So next we have the concept of ventilation, minute ventilation and alveolar ventilation. So what is minute ventilation? Abbreviated as VE. This is the total volume of gas entering the lungs per minute. The total volume of gas entering the lungs per minute is minute ventilation. What's the formula? VE, which is minute ventilation, equals tidal volume multiplied by respiratory rate. Normal values of respiratory rate, it's 12 to 20 breaths per minute. Tidal volume we saw earlier is 500 ml per breath. VD, which is the dead space, is 150 ml per breath. So from these, VE equals VT into RR. So that's the minute ventilation. Next, we have alveolar ventilation, abbreviated as VA. The volume of gas that reaches the alveoli. This is what is entering. This is what is reaching the alveoli. So the volume of gas that reaches the alveoli in each minute. VA equals VT, what came in tidal volume, minus the dead space into the respiratory rate. That's what's reaching the alveoli. Tidal volume which came in minus the dead space multiplied by RR. VE equals VT into RR. VE equals VT into RR. VA is VT minus VD into RR. VE equals VT into RR. VA equals VT minus VT into RR. Respiratory rate comes in both. इसमें additionally alveolar ventilation, you have to subtract the dead space. Okay. TXRR. So TOR is in both. Here we have to just add the door, the VD. VT into RR, VT minus VT into RR. Okay. Moving on. Next, we have lung and chest wall properties. Because of historical reasons and small pressures, pulmonary pressures are always present in centimeter of water. Because of historical reasons, Barson say they've been doing it, so they left it. And small pressures, so very small changes. So that's why pulmonary pressures are measured in centimeter of water, because it measures tiny changes compared to millimeter of mercury or whatever it is, physics. So because of historical reasons and small pressures, pulmonary pressures are always measured in centimeter of water. So what are the lung and chest wall properties? We have elastic recoil, compliance, and phenomenon of hysteresis. Okay, so let's see. Elastic recoil is the tendency for lungs to collapse inward. Recoil, right? So they have to collapse inward, and chest wall to spring outward. What is elastic recoil? The tendency for lungs to collapse inward and the chest wall to spring outward. So lungs will tend to collapse inward because they have elasticity. Chest wall are ribs, so they will tend to spring outward. So at FRC, which is functional residual capacity, airway and alveolar pressures, meaning what pressure in the airway and pressure in the alveoli, equal the atmospheric pressure, which is PB called 0. Barometric pressure called 0 point. So at functional residual capacity, the airway and the alveolar pressures are equal to the atmospheric pressure. So what is under is equal to what is bahar. Airway and alveolar pressure is equal to atmospheric pressure. So PV called 0, and intrapleural pressure is negative. It means in the pleural space, it's a suction force. Negative meaning it is a suction, pulling down force. So preventing atelectasis. It makes sense, right? If it's a vacuum cleaner like thing, it's suctioning. So it'll prevent collapse. So the inward pull of the lung is balanced by the outward pull of the chest wall normally. Yes. Inward pull of the lung is balanced by the outward pull of the chest wall. System pressure.
Sorry, FRC, airway and alveolar pressures. Where is this alveolar and airway and alveolar pressures equal atmospheric pressure? What is this PB?
Barometric pressure, right? The pressure in the atmosphere. That's the symbol for atmospheric pressure. I think so.
Okay. Okay, so FRC, they are saying that airway, which is outside, and alveolar pressures, which is inside.
Yeah. So under or bahar, dono same at functional residual capacity.
Airway means outside or in the lungs? Airway से उसका क्या मतलब?
Airway means जो भी conducting zone है plus the airway pressure दोनों को मिला के this pressure, if you add it up, airway pressure in the conducting zone and the alveolar pressure is equal to the atmospheric pressure जो बाहर हवा में है. So the airway and the alveolar pressure equals the atmospheric pressure at the functional residual capacity.
Okay.
So that's what they're saying.
So FRC, airway and alveolar pressure is equal atmospheric pressure. So PB is called 0. And the intrapleural negative pressure is negative. Okay, so intrapleural pressure is negative, which is, I think, inspiration -10 and expiration it's -5, but it's always negative, right?
Correct, exactly. No? Yes, it's always negative pressure. So if you see here, it is -10 and -5 to -10. It varies between -5 to -10, you're right.
Okay.
But it'll always remain negative, yes. Remain negative, but can become less negative and more negative and so on. Just they use the words and confuse us. but less negative or more positive relatively, but it will still be a negative value always. So suction
Okay.
pressure, it's a negative pressure, yeah.
Thank
And
you.
then they said the inward, no problem. The inward pull of the lung is balanced by the outward pull of the chest wall. So there needs to be a balance. Otherwise, what will happen? The inward pull of the lung will be so much कि सब अंदर से collapse हो जाएगा lung. बाहर से pull होनी चाहिए and this should be in a balance. So the inward pull of the lung is balanced by the outward pull of the chest wall. So it stays in a residual, like residual capacity. So residual capacity we said was what? Volume of gas in lungs after normal expiration. So at this time, जो अंदर है वो बाहर है, it's matching. The airway and the alveolar pressure is matching what is in the atmosphere. Okay. Anyway. System pressure is atmospheric. Pulmonary vascular system pressure is atmospheric. I don't know what they mean by that. System pressure is atmospheric. Pulmonary vascular resistance is at minimum. Pulmonary vessels ki resistance is the lowest at this point. Does anyone get this one? Systemic pressure is atmospheric. What do they mean? Pulmonary vascular resistance is a minimum. Is at a minimum. Okay. At the FRC, they're talking about. Okay. At functional residual capacity, the pressure in the pulmonary vessels is at a minimum. Okay, that's fair, but I don't understand the system pressure. System pressure is atmospheric. Not sure about that. Okay, anyway, so then next is
At the FRC, like agar just go to the above page, no? How means why they're saying that the pulmonary, yeah. So at this level, the pulmonary resistance, vessel resistance is minimal. So how would we interpret this? Like,
so what is functional residual capacity? The volume in the lungs after normal expiration. जो पीछे रह गया है after normal expiration, that's the functional residual capacity. At this point of FRC, the pressure in the pulmonary vessels is minimum. So pressure in the pulmonary vessels is minimum, meaning no, resistance is minimum. Sorry, resistance is minimum. So they are retaining this leftover air, right, in the lungs. So resistance is minimum because the lungs are now retaining some volume capacity. I'm just saying roughly my understanding, I might be wrong. So जो पीछे रह गया, this is all air. So pulmonary resistance.
resistance अगर vessel की कम होगी तो उस पे load होगा ना, like oxygen would load back, right? Because resistance कम है.
Resistance का मतलब they will be more loose, right? They'll be open. They'll receive all the air and the blood.
Yeah, exactly. But ये तो expirations का है ना, FRC is at the expiration level. मतलब if it would be like IC, inspiratory capacity, that would be like, I mean, I know I'm wrong, but I don't have concept. That's why I'm asking. क्योंकि inspiratory volume में alveoli would be filled with the oxygen. That time the vascular, the pulmonary vascular resistance would be minimum so that the oxygen would load to the vessels, right? From the alveoli to the vessels. So why they're talking everywhere that FRC को क्यों बना रहे हैं इन लोग? Like, I mean,
yeah, you are right, right? What just you said at this point. So we are saying itna reh gaya bahar, but this is where the maximal inspiration has occurred. Actually, something you said it clicked, but then I lost it. So at this point, although residual volume they're talking about, at this point, if you see on the other side, what happened, we have maximally inspired and expired to some point, then further going down. So at FRC point, what has occurred is tidal volume we finished, inspiring, full inspiration has happened, full expiration also has happened. So at this point, the pulmonary resistance is less because think about it.
Residual volume to वैसे भी exchange नहीं होएगा. That air never gonna exchange, never gonna,
Mhm.
But then, I mean, if it is not higher, just leave it. But मेरे को वो नहीं समझ में आया कि इन लोग FRC को ही हर चीज का main point क्यों बना रहे हैं? Why they are making it like at the FRC level? Why it is so significant to talk about whole the process at the FRC level?
Functional residual capacity, let's see, maybe we're missing something. This is the volume of gas in the lungs after normal expiration. So this is like the cutoff point where outward pulling of the chest is balanced by the inward collapsing force. So that's why they're calling it functional residual. So the under like at this point, the outward pull of the chest wall is balanced by the inward collapsing force of the lungs. So that's why they keep bringing up the FRC.
It is a kind of the balancing point.
Yeah, that's the balancing point
Mm.
between the inspiration, no, actually recoil force, which is the
हाँ सही है वही
inspiration, and inspiration is the, yeah, it's actually the balance between inspiration and expiration. Can we say that?
why not? Yeah, kind of.
I mean, is it correct logically? Inspiration and expiration has occurred a little bit, so no, maybe not.
Not a
But-
balance, but yeah, I mean recoil inward and outward, at least it is the same, right?
Yeah. So inward coil is inward and outward forces are balanced. That's why they keep talking about FRC point.
And even they are talking about the atmospheric pressure is like compared to the inside the lungs, right? Because whenever it goes zero, then only you will inspire it out, right?
Exactly. Yeah. So at that point, the airway pressure and the alveolar pressure, the sum of that is equal to the outside. So that matches it, right? Because if atmospheric pressure was more, then things will change, which we see in like some questions.
Makes sense.
So yeah, this FRC is the point. For now, what we need to just remember is FRC is a point, outward pulling force is balanced by the inward collapsing force. If we see here, this outward pulling force is responsible for inspiration, right? The lung wall, chest wall has to open up for inspiration. And the lung has to recoil for expiration. The lung has to kind of collapse or push everything out. So that balancing point is the FRC, I think. Let's see, maybe we'll get some more clarity as we go. It's been a while since we did column sessions.
But I understood what you said and it makes sense. So, ये pulmonary
Can
वाला
we get some
That's what zero, right?
15 minutes break, please? If possible.
Okay, fine. Let's take a break. So we'll come back and start this lung chest wall properties again.
Yes.
Then let's try to do at least physio, maybe. Is this
इसमें
doable?
कितने 28 pages है ना?
Yeah, I don't know. Total was less only 28, 30 something.
20.
Let's see whatever we can do well till 7:30, 7:45, and then we'll stop. Because anyway, there's lots of concepts, so it will take time, I think. It's okay, okay, no worries.
Thank you,
Okay,
Sarah.
guys, let's take a 15-minute break and freshen up and come back for dhamakas. Take care. Okay, so starting over lung and chest wall properties, because of historical reasons and small pressures, pulmonary pressures are always present in centimeter of water. What are the three main properties? Elastic recoil, compliance, and hysteresis. What is elastic recoil? It's a tendency of lungs for the lungs to collapse inward and the chest wall to spring outward. At FRC, functional residual capacity, which is the equilibrium point, airway and alveolar pressures equal the atmospheric pressure. What is atmospheric pressure? Symbol is PB, and this is at 0 centimeters of water. And intrapleural, at this FRC capacity point, intrapleural pressure is negative, preventing atelectasis, and inward pull of the lung is balanced by the outward pull of the chest wall. Systemic pressure is atmospheric, and the pulmonary vascular resistance is at a minimum.
What is PB? Sorry, I missed it.
PB was barometric pressure. It's the
Okay.
symbol for the atmospheric pressure. And at FRC point, this barometric pressure is 0, which is the atmospheric pressure is 0. So as Faiz shared, the UWorld question image, put it side by side. So you have to correlate at functional residual capacity, which is this balancing point. The airway and alveolar pressures equal the atmospheric pressure, which is called 0.0, or they measure at 0 centimeter, which is here. And the intrapleural pressure is negative, preventing atelectasis. The inward pull of the lung is balanced by the outward pull of the chest wall. System pressure is atmospheric, pulmonary vascular resistance is at a minimum. So here they said, on the above pressure volume curve, the collapsing force is positive. Measuring it's positive, more positive measurement. Collapsing pressure is positive. And yeah, if you think of plus 10, it's going to push, right? So positive pressure, whereas the expanding pressure is negative. It's on the negative side if you measure it. It's very less pressure, so it's negative. The lungs have a tendency to collapse at all lung volumes. So the entire lung curve is located in the positive region. In contrast, the resting chest wall has a tendency to expand at all but very high lung volumes. So most of the time it has a tendency to expand. Therefore, most of the chest wall curve is located in the negative region. Negative meaning it has very less force. It's a small number versus positive is collapsing because it's a higher number. The point where the collapsing force of the lung is equivalent to the expanding force of the chest wall is known as the resting equilibrium point of the respiratory system. And that is the end tidal expiration, end of the tidal expiration, represented by the black dot. I think it's this one. So the alveolar pressure at this point is equal to the atmospheric pressure, which is 0 centimeters of water. And the lung volume that is available in the lungs at that point is the functional residual capacity. So the FRC, as in converse, as we said, reverse learning at FRC point, inward pressure and outward pressure are balanced out. So it's 0. So that's why they keep bringing that up. Okay. So the question in this, the question picture in the scenario is what Fraser shared. The combined compliance of the lung and chest wall of a healthy individual is measured and plotted as shown below. This black dot actually they were referring. It's noted that the intrapleural pressure at the end of maximal inspiration is -8. Which of the following is the best estimate of the intrapleural pressure at the point marked by the black dot? So this is all story. Now they're just saying which of the following is the best estimate of the intrapleural pressure marked by the black dot. And the correct answer was it has to be a negative pressure. So we rule out A, B, and 0. Intrapleural pressure is always negative, as we saw from this one. Why was it not -10? Because maximum is, I guess, -8. Okay, let me read this. So on the above pressure volume curve, the collapse pressure is positive. On the above pressure volume curve, the collapsing pressure is positive. We are talking about this curve, I think. On the above pressure volume curve, the collapsing pressure is positive and the expanding pressure is negative. The lungs have a tendency to collapse at all lung volumes. Therefore, the entire lung curve is located in the positive region. This is what I just read, actually. In contrast, the resting chest wall has a tendency to expand at all but very high lung volumes. Therefore, most of the chest wall curve is located in the negative region. Chest wall curve is most of it is in the negative region. The point where the collapsing force of the lung is equivalent to the expanding force of the chest wall is the resting equilibrium of the respiratory system. That is the end tidal expiration point. End of tidal expiration is what is measured, you can say represented by the FRC remaining at that point, end of tidal volume. So this part is nothing but the functional residual capacity. So represented by the black dot in this question. The alveolar pressure at this point is equal to the atmospheric pressure, which is 0 centimeters of water, and the lung volume is at the FRC. Compliance is defined as a change in volume per change in pressure and is represented by the slope of the pressure volume curve. So that's combined compliance. A highly compliant container is able to stretch to accommodate large increases in volume. Sorry, compliance is defined as change in volume per change in pressure and is represented by the slope of the pressure volume curve. A highly compliant container is able to stretch to accommodate large increases in volume with little change in pressure, demonstrating a steep compliance curve. Generally, lung compliance is greatest around the FRC and decreases at very high and very low lung volumes. So greatest around the FRC again. And decreases at very high and very low lung volumes. Note that surface tension causes compliance to differ during inspiration and expiration, which is a phenomenon known as hysteresis. We'll see it next. So the chest wall has low compliance at low lung volumes and becomes more compliant as lung volume increases with inspiration. The chest wall has low compliance at low lung volumes. So compliance is like a grocery plastic bag, right? So chest wall has low compliance when the volume is less. It won't open up as much if there's low lung volumes. And it becomes more compliant as the lung volume increases with inspiration. So the more air you fill in the plastic bag, it becomes more compliant, which makes sense. So now it becomes more compliant as the lung volume increases with inspiration. The compliance of the respiratory system as a whole is the combined compliance of the lung and the chest wall put together, which is represented by the blue curve. Intrapleural pressures are not represented on the lung pressure volume. Sorry, intrapleural pressures are not represented on the lung pressure volume curve. The expanding force of the chest wall working in opposite direction. Sorry, one more time. Intrapleural pressure, so pressure inside the pleura, they are not represented on the lung pressure volume curve, not measured here. The expanding force of the chest wall working in opposite to the collapsing force of the lungs creates a negative intrapleural pressure throughout the respiratory cycle. The expanding force of the chest wall, which is going outside, working in opposite direction to the collapsing force of the lungs working inside, creates a net effect is negative intrapleural pressure. In the pleura, between the two layers, it's going to be a negative intrapleural pressure. This is happening throughout the respiratory cycle. So that's what, as Hamna said, it's always going to be negative in the pleural space, or intrapleural pressure. Inspiration is driven by active expansion of chest wall, which generates an even greater intrapleural pressure, negative pressure, and pulls the lung outward. Inspiration, when we inspire, what do we do? This is driven by active expansion of the chest wall, which generates an even greater, so the pressure will drop further inside, right? So it generates an even greater intrapleural negative pressure and pulls the lungs outwards. Intrapleural negative pressure peaks at a maximal inspiration at a value of approximately -8. Peak possible is -8, so -10 was wrong. During passive expiration, the chest wall relaxes and the respiratory system returns to its equilibrium position, in which the intrapleural pressure is approximately -5. So the lungs generate a collapsing force and the chest wall generates an expanding force. The point at which these two forces, opposing forces, are equivalent is the resting equilibrium of the respiratory system, where the alveolar pressure is equal to the atmospheric pressure. And the lung volume, the amount of the volume in the lung volume is the functional residual capacity. The opposing forces create a negative intrapleural pressure throughout the respiratory cycle. Intrapleural pressure at resting equilibrium, which is the end tidal expiration, is approximately -5. So this they're asking specifically at resting equilibrium. One more time, sorry. The opposing forces create a negative intrapleural pressure throughout the respiratory cycle. So pleural pressure is what they're asking. So that will be a negative pressure, which is why the options were between D and E, and the peak is -8. So it cannot be choice E. So the opposing forces create negative intrapleural pressure throughout the respiratory cycle. Intrapleural pressure at resting equilibrium, that is end tidal expiration, is approximately -5. More negative intrapleural pressure when inhaling. Yes, and less negative intrapleural pressure when exhaling. Less negative. More negative in inhaling. Really? More negative intrapleural pressure when inhaling. Yeah, rate of intrapleural pressure. Inspiration is driven by active expansion of the chest wall, which generates an even greater intrapleural negative pressure. More negative, yes. Agreed, okay. And pulls the lung outward. Intrapleural negative pressure peaks at a maximum inspiration at a value approximately -8. Okay. Okay, cool. Anyone able to explain this in better words, please? Go ahead. I think I'm understanding, but verbalizing is not as easy.
I think what I get it,
Mm-hmm.
in any case, basically, intrapleural pressure has to be negative.
Mm-hmm.
On inspiration, it's -10, so that more negative pressure will pull, obviously will pull the air inside, right? During inspiration, -10. And on expiration, it's going to be -5 because we are pushing the air out, right?
-8 on maximum inspiration.
-8 or -10?
-8.
Okay, -8 on maximum inspiration, and then on expiration, it's gonna be -5, right?
-5 is resting. So as you breathe, it goes down. It goes down. You see this graph right on top. The most lowest one, intrapleural pressure. So as you breathe, it keeps going down. 6, 7, 8. I think maximum, as he said, it's a. But if you do full expiration, more than the beyond the FRC, it'll go down to 10, and then as you exhale, it keeps on going less negative. We don't associate positive with intrapleural pressure. It's either more negative or less negative.
Okay.
I like what you said. More. We don't say positive. It's either more negative or less negative.
So more negative with
More
inspiration and less negative with expiration, right? Yes.
Yes.
Okay, got it. Thank you so much. So, so the point at the FRC, which is the main midpoint, I think at that point, the inward pulling force of the lungs is equal to the outward, the inward collapsing force of the lung is equal to the outward pull of the chest wall. We got it.
That's 0 alveolar pressure, and that's -5 intrapleural pressure, right?
Okay, that's zero atmospheric pressure and -5, you said?
Intrapleural.
Okay, at -5 intrapleural pressure. Okay, so at that point, which you show in the figure, at that point, basically two forces are opposing each other and they are like maintains a balance at FRC.
Yes.
So this
But sorry, I didn't get the other part, please. Sorry.
The top part is just the volume, right? The lung volume. That has to do with like compliance. So in compliance increase in, let's say, emphysema, right? And compliance decrease in pneumonia. Those are like pathologic normal conditions, and then it will expand and decrease based on pathology, right?
Yeah. So this is basically when you inspire, the volume is going from 0. That's where the FRC, we said, that's at the point at 0.0, for example, where at that point only what is residual is remaining. So when you inspire, this volume goes up, right? You're taking in air, you're taking in air, so it's going to increase from some 0 volume, it went to 5 liters, which is 500 ml. 0.5 liters, which is 500 ml maximal tidal volume. And then when we expire, we breathe this out. So that's what they're shown here. From 0, which is the functional residual capacity point, equilibrium point, increased volume going up to 500 ml. That's the max tidal volume usually. And then when we expire, we breathe it out and come back to this resting equilibrium point. So this is easy. And then, as you said, this is from a less negative intrapleural pressure, which is baseline. No, is at, okay, so from -5, when we inspire, correct. So when we inspire, the lung is basically the cavity is opening up. So the pressure is kind of dropping. So it's becoming -5 going down to minus, what is this, around -9.
Saira, when we are inspiring, right? So जो pleural space है, correct? वो कम होगा, right? Like just inhale. When you're inhaling, the lungs is expanding, correct? So in between, the pressure in between the pleura is, do you think like it's kind of वो दोनों pleura पास आ रहा है, visceral and parietal pleura is coming together, right? When we are inhaling, taking up the air, correct? तो जब स्पेस कम हो रहा है तो उसका नेगेटिविटी और कम होगा, करेक्ट? लाइक दिस इज अ ले वे टू रिमेम्बर दिस थिंग जो मुझे अभी लग रहा है, राइट? एंड व्हेन वी आर एक्सपायरिंग, सो a pressure of the visceral pleura is stretching it inward, and chest wall parietal visceral pleura को lungs is like inward की तरफ खींच रहा है, and chest wall parietal को बाहर की तरफ, right? So उन दोनों के बीच का गैप थोड़ा बढ़ेगा तो लेस नेगेटिव, वहां की प्रेशर थोड़ी सी लेस नेगेटिव होगी. I mean, did I make any sense or I confused everyone? Did you understand? Like,
I think this part I got, this also I got, but can you repeat that just so it cements in my head? So you said when you're going from -5 to -10, which means you're taking in air, the lung is expanding. So the space, like as you said, the space between the lungs and the chest wall is decreasing. So there's kind of a more negative pressure.
So there is more pressure coming in, right? More pressure. When you are reducing the space between the two pleura, between anything, the pressure would increase, correct? Right?
Yeah, so like the diaphragm contracts, right?
Yeah.
And the rib muscles expand. right? So both goes for, so it goes for both alveolar and interpleural. So they both work the same way. As you breathe, the diaphragm contracts, the alveolar, the sacs exchange air, your interpleural pressure goes more negative, right? As you exhale, you let it out, you let the air out, it less negative. Whereas alveolar pressure is different. Alveolar pressure, it becomes negative, but then it becomes positive too. That's why we differentiate intrapleural and alveolar pressure based on negativity. Intrapleural pressure is always negative, whereas alveolar pressure works the same way Shruti explained. It works in we can associate it with the same way, but the only difference is it becomes positive because we are dealing with alveolar small sacs in the alveoli, right?
Hmm.
The air sacs, because we are talking about gas exchange.
And whatever negative we are talking here, no, we are talking irrespective of the outside atmospheric, which we are taking ideally 0. Right? I mean, correct me if I'm wrong. But that is not something significant for doing the boards question, I guess. Just that, I mean, I understood this intrapleural in this way, like, when we are inhaling, lungs is expanding, the interpleura means दो प्लूरा के बीच, visceral और parietal प्लूरा के बीच. तो जब expand कर रहा है lungs, तो इन दोनों के बीच का गैप कम हो रहा है. जब कहीं का भी गैप कम करते हो आप, तो वहां का प्रेशर इंक्रीज होगा. और इंट्राप्लूरल कभी भी मतलब इट इज ऑलवेज भी नेगेटिव ओनली, राइट? एंड जब आप एक्सपायर कर रहे हो, तो आपका जो विसरल प्लूरा है वो अंदर की तरफ खींचता है, पैराइटल बाहर की तरफ, चेस्ट वाला उसको बाहर की तरफ खींच रहा है. तो देयर इज द स्पेस इंक्रीजिंग इन बिटवीन, सो देन दैट इज गोइंग टुवर्ड द अबव, बट इट इज लेस नेगेटिव. दैट इज व्हाट आई मीन. आई अंडरस्टूड इट इन अ very lay way.
So you said pressure is increasing in that space on inspiration, right?
Yep. क्योंकि आप दो वॉल को कम कर रहे हो ना, like there is like where it would go, right?
Versus when we expire.
तो वो ऊपर की तरफ जा रहा है. पहले कम जब हो रहा है, जब so it is ऊपर की तरफ जा रहा है, so it is less negative.
Okay.
So yeah. So more negative here, it means pressure is increasing. The less negative here is pressure is decreasing.
Yes, that's why it is.
Yeah. Sorry, I didn't mention that.
More negative means pressure is actually dropping.
Pressure is increasing.
Wait, more negative means intrapleural pressure.
Oh, mathematics वाला मत use करना आप यहाँ पे, like that would confuse you up. More negative means pressure is more.
More negative, more inflation of the lung, more better breathing. That's how I see it.
Yeah, but in between, intrapleural pressure is increasing, right? I mean, correct me.
Yes.
Means what Sarah has written is correct, right? This is what it happened naturally.
I used to think of it as a suction pressure, like diaphragm, as you said, was contracting. So if you think about like this is the lung and diaphragm is contracting, pulling it down, it's more like a suction pressure, right? More suction pressure. So pressure increases, more negative.
So that is the lungs का सारा. एक और triangle के ऊपर एक और triangle आप बनाओ.
I mean to say this pressure between the two, the pleural space.
Thoracic cavity, yeah.
So this contraction of the diaphragm and all the respiratory muscles will create a more negative pressure. So everything opens up like a suction pressure. Like how do it's diaphragm is pulling down. I think if you even think of just as diaphragm is pulling down with more force. Okay, I don't want to confuse, but I think I like what you said. जो दो space के बीच में जो pressure है, -5 से -10 पे जा रहा है, not -8, 10, but it's going more negative. And then when we expire, this air is going out of the lungs, so the pressure also becomes less negative.
आपने जो बोला ना, that is correct. Diaphragm is pulling it down, but inside air is also coming, no? So ये जो अंदर वाला circumference है, वो ज़्यादा expand करेगा, तो ये दोनों का gap कम हो जाएगा inspiration में.
Yeah, I like what you said. So this
Hmm.
pressure also, the space goes
More closer, yeah, more closer to each other. Yeah.
nice.
And when the expiration would happen, the outer circumference one, the outer green color one, the chest wall is pulling it outside. And inside, what would happen? Inside circumference, the lungs wall, the parenchyma would be pulling it quite inside. So the space in between these two would be increasing. Once it is increasing, what would happen? Pressure would drop. That is less negative.
Nice.
But I mean, that's what I understood. If any change is there, just correct me.
No. Yeah, you got it. So what Saira, please correct me if I'm wrong. So she says that when we inspire, so दो pleura के बीच में जो आपकी space है वो ज़्यादा because they are coming close to each other, pressure is increasing. It becomes -8. So pressure is increasing, right?
Yes.
On inspiration, that helps in the inspiration basically. Helps in the air coming into the lungs. And when we expire, so outward pull of the chest basically वो बाहर खींच रहा है और lungs अंदर की तरफ अपने आप को लेके जा रहा है, right?
Yes, exactly.
तो वो आपकी जो space है वो आपकी dilate हो रही है, supposedly space का gap बढ़ रहा है, ठीक है? Pressure उसमें आपका कम हो रहा है और वो आपके पास less negative हो रहा है, which is -5.
Yes. ये shrink हो रहा है lung.
Expiration में.
Expiration में, we talk about expiration now.
हम्म,
और यहाँ पे the chest wall is बाहर से खींच रहा है ना, this is going
बाहर
outside.
से खींच रहा है. Okay.
So यहाँ पे क्या हुई, space बढ़ गई. Is what we are saying, right? Space बढ़ गई, तो less negative हो गया, pressure कम हो गया. Correct? This is what you're saying. So the lungs,
Yes.
this is for expiration phase. So from the minus pressure, so again, even for the diaphragm, with respect to diaphragm is now pushing up. When we're expiring, it will be like this. So lungs are being pushed out, lungs are also collapsing, but the ribs, like when we talk about the ribs, they are normally going to So what did you say, Shruti? The ribs are always going to be new, like they're going to be pulling out. So the
The
space
visceral pleura, the chest wall, right? So
between the visceral and the parietal is increasing.
That was actually parietal, no? Ribs तो parietal pleura को पकड़ेंगी नहीं.
Sorry, this is parietal, this is visceral.
सही बोल रहे हो आप. Like whatever you guys are saying is the correct analogy.
But what's slightly confusing me is the ribs actually pulling out in expiration?
Expiration.
Like inspiration में they pull it out, expiration में
नहीं देखो, अगर हम जैसे what is the recoil is what, अगर like we think that anterior posterior diameters and all the diameters has decreased when we expire, correct? But then what is happening, there is the counteract forces also happen, no, that it is pulling, it cannot go inside the outside chest wall, it cannot go inside. Do you get that? Like
you're right. The intrinsic property of the ribs should be to pull outside. नहीं तो पूरा lung
exactly.
बंद हो जाएगा ना. So
Yeah,
this
collapse would happen, right? So yeah.
Okay, nice. So this in inspiration, only the parenchyma will shrink inside and exhale the air out through the bronchi. And the lungs, the rib cage is still trying to pull the things outward.
Yeah, chest wall is, yeah.
Chest wall. So in this phase, the pressure is going from more negative to less negative. Pressure, which was first high, because in that phase, they were very close to in contact with each other in the inspiration phase. So there they were pushing each other, so pressure was negative, or in other words, pressure was high. Now there's more space, so pressure dipped, so it's less negative. Correct? Okay, nice. Okay, I think I got it. Just need to cement it more.
I have
That's
no
fine.
idea when the question would come, I'll be able to do or not. That I don't know. But like
This was good. Thank you so much. Yeah, it does. Both of y'all were like you guys said, it's it's getting consolidating. Three of you, actually, all of y'all. Okay,
Yeah, thank you so much.
thank you. Hamna, did you finish? You were saying something actually. Are we good?
No, I'm fine. जितना आ गया उतना ही काफी.
Okay. Okay, cool. Thank you. Thank you all. So yeah, lung volume pressure goes up and then comes down. Hits tidal volume goes down. Alveolar pressure, it goes negative, then comes back up positive in the inspiration itself. Inspiration, alveoli will expand and then they start beginning to collapse so that they can push air out, because here we said, as I said, this was gaseous exchange stuff. So it becomes negative and positive in inspiration itself. Again, it becomes positive and negative, positive and coming back to zero in expiration. So pressure in the alveoli increases slowly, fills up with air. Then there's so much distension that now they can no longer expand. So they slowly start collapsing. Then they reach the equilibrium. Then again in expiration, they start pushing the air out further, and then they come back to equilibrium at zero. Intrapleural pressures -5, then it dips and becomes more negative, then goes back to being less negative. Okay. Okay, cool.
So, Saya, what is lung volume and alveolar pressure? How would you just differentiate between lung volume and
kitni air andar ja rahi hai, that's the lung volume. Alveolar, like if you take a single alveoli for example, एक alveoli लेके इसमें pressure हम लोग measure कर रहे हैं, तो उसका क्या pressure रहेगा, we are measuring.
Okay.
So this is the amount of air entering and leaving. This is individually alveoli को लेके, if you measure इसमें pressure कितना है, that's the thing. So this is a volume and this is a pressure. Pressure matlab है, how do you say? Force, right?
Yeah. Okay. Yeah. Force.
Single
So
pressure.
normal VT is actually 500 ml, right? So 5 liters, I guess.
0.5 liters.
0.5 liters. Yeah.
It's the same as 500 ml. Yeah.
Okay. Thank you.
Thank you. So yeah, so that was elastic recoil. Thanks all. The tendency for the lungs to collapse inward and chest wall to spring. Tendency for lungs is to collapse inward and a chest wall to spring outward. At FRC, the airway and alveolar pressure is equal to atmospheric pressure, which is PB, and this is called zero. At intrapleural pressure is negative, preventing atelectasis. The inward pull of the lung is balanced by the outward pull of the chest wall at FRC. System pressure is atmospheric, ye pata nahi kya keh rahe hain, but anyway. Pulmonary vascular resistance is at a minimum. This also not really clear, but pressure in the
these are the conditions for actually elastic recoil. First one is that at FRC it's equal, inward pull is equal to the outward pull of the chest wall. Second is that pulmonary vascular resistance should be at its minimum level, and the other one is that the other one is that at FRC it's airway and alveolar pressure is equal to the atmospheric pressure, and intrapleural pressure is negative. So these are the conditions for the elastic recoil.
Okay.
First, second, and third.
Okay. System pressure is atmospheric, matlab zero, because we said this is equal and this is zero. So the whole system pressure is usually zero at elastic recoil. It has to be zero. I think that's what they're saying. But anyway, so this is a feature. This is a requirement. So this is going to be system pressure is atmospheric. And the pulmonary vascular resistance is at a minimum. Okay. Next, we have compliance, which is change in volume for a given change in pressure. which is delta V over delta P. Change in lung volume for a change in pressure, delta V over delta P. This is inversely proportional to wall stiffness and is increased by surfactant. So delta V by delta P, so change in the volume and pressure over pressure, is inversely proportional to wall stiffness. If it's more stiff, more the change in volume over pressure. If it is less, okay, let me see. I'll go there. So inversely proportional to wall stiffness and increased by surfactant. So the delta, the change in volume over pressure, is increased by surfactant. Which means if surfactant is there, it's able to move more. If there is increased compliance, the lungs are easier to fill. Yeah, increased compliance, the lungs are easier to fill. Example, emphysema in older adults. With increased compliance, yeah, so like the plastic bag example. So increased compliance, lungs are easier to fill, as in the case of emphysema in older adults. With decreased compliance, it's like a hard substance, like a vessel. So decreased compliance, the lungs are more difficult to fill. For example, pulmonary fibrosis, pneumonia, ARDS, and pulmonary edema. Like a bucket, like a pail or something. So decreased compliance, lungs are more difficult to fill. Example, pulmonary fibrosis, pneumonia, and ARDS. Okay, so that's compliance. What is it? Compliance, a change in volume for a given change in pressure. If pressure डालो तो कितना volume change होगा is something like that. Okay. Change in lung volume for a change in pressure inversely proportional to wall stiffness and increased by surfactant. So what we need to know, it's inversely proportional to the wall stiffness. Yeah, it makes sense, right? If stiffness is more, change will be very less. Okay, makes sense. Inversely proportional to wall stiffness and it's increased by surfactant. Okay, yes. Where do we see increased compliance in case of, what is the scenario? This is lungs are easier to fill, like emphysema in older adults. Where do we see less compliance? Lungs are more difficult to fill, like pulmonary fibrosis, pneumonia, ARDS, and pulmonary edema as well. Yep, they're filled with fluid or they're fibrotic. Again, pneumonia, infectious material, ARDS, damage to the tissue. So the compliance will go down. They're not going to be as expansive, not as stretchy. So compliance goes down. Okay, next we have a phenomenon of hysteresis. Here, lung inflation follows a different pressure volume curve than lung deflation due to the need to overcome surface tension forces during inflation. So the lung inflation follows a different pressure volume curve than lung deflation, because deflation is easy, nothing stopping it. But for it to inflate, it has to overcome the surface tension forces. So this phenomenon is known as hysteresis. So what did it say? Sorry. Inflation, lung inflation, which is inspiration, follows a different pressure because lung inflation has to undergo surface tension forces. Deflation, which is expiration, is easy. So inspiration, it's a different curve because it has to overcome the resistance given by the surface tension. Usko par karke, this will open up. Expiration is just down, just it's easy, nothing stopping expiration or collapsing. Deflation, so this is just gonna quickly come down. So this is a different curve. This difference is known as hysteresis. Where did they say it in words? They didn't. Okay, but that makes sense, right? Anything else? Any add-ons for hysteresis?
So in inspiration, more work is needed basically, because we have to overcome the surface tension.
Mm.
But in expiration, what happens? It's the surface tension basically helps to exhale the air out. That's why less work is needed.
Exactly. Yep. So here they said lung compliance demonstrate hysteresis, that is the compliance differs during inspiration and expiration due to the effects of alveolar surface tension. The flatness of the inspiratory lung compliance curve at very low lung volumes reflects the difficulty. This region is because it's trying to push and overcome the surface tension. So the flatness of the inspiratory lung compliance at very low lung volumes reflects the difficulty in initiating a collapsing lung. Difficulty in inflating a collapsed lung, and represents a decreased compliance compared to that at the FRC. FRC is this point. So after this, it's already overcome the resistance. So it's easier. And expiration, nothing is stopping it. So zoop, it comes down. Here it has to, for it to inflate, it needs to overcome the surface tension. This phenomenon is known as hysteresis.
Sarah, what is in this question? They ask hemithorax volume and inspiratory lung compliance.
So 18-year-old previously element comes with the ED after being stabbed in the chest. Blood pressure is 130, blah, 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 and oxygen saturation is 96%. Physical exam reveals a 2.5 centimeter stab wound on the right lateral chest wall. Breath sounds are decreased on the right side. Chest X-ray is shown. So there is a collapse here. So then they're asking, which of the following changes have most likely occurred in this patient's right hemithorax compared to the pre-injury state? Hemithorax volume will go up because it's now just empty, and lung compliance is decreased. So if you take the example of a grocery bag or a garbage bag, if it's collapsed, then uska compliance kam hua na. So collapse is always be decreased compliance. Compliance is how much it can open up. So this is a collapsed lung. So under shrink hoke baitha hai. So compliance is less in this case. Hemithorax volume.
Yeah, got it. Thank you.
Sarah, I didn't get it. Like when it is shrinking, then compliance कम कैसे हुआ? तो ज़्यादा है, इसीलिए तो shrink कर गया, नहीं?
Compliance is the
No.
ability for something to open.
Compliance is like a shopping bag. When you push the air, so it expands and it retains its volume. Like shopping bag के अंदर अगर आप भरते रहो तो वो expand होगा, लेकिन उसके बाद फिर वो वापस नहीं जाएगा. वापस जाना तो elastic recoiling है.
Right.
इसमें चीजें भर रहे हैं तो compliance जो बाहर खुलता है बैग, that is compliance.
Yeah.
So here ये तो collapse होके बैठा है ना, this is closed. So the compliance is going to be opposite. This expanding force is compliance. As Hamna said, collapsing force is the recoil.
Correct.
Like for example, the balloon, I think someone used to say on the group, the balloon when it deflates, that's the recoil, right? ये हवा बाहर जा रही है तो collapse हो रहा है, so that's the recoil force. Elastic recoil, yes. So this inward collapsing force is the recoil.
Thank you, guys.
You're welcome. So here it says the lungs exert collapsing force and the resting chest wall. So this is the concept which is important. The lungs are exerting a collapsing force, so the compliance went down. The resting chest wall, as you said earlier, is going to, even at rest, it exerts an expanding force. This is the key word. Resting chest wall exerts an expanding force. So these opposing forces are in equilibrium at the FRC and generate sustained intrapleural negative pressure that allows the lungs and the chest wall to move together as a combined respiratory unit. The loss of negative intrapleural pressure, as in a pneumothorax, disrupts the combined system, causing the chest wall to spring outward to its equilibrium position, enlarging the hemithorax. So that's why the hemithorax volume went up. Similarly, the lung, on the other hand, is collapsing to its equilibrium position where the inspiratory compliance is decreased. It's collapsed, so the compliance is decreased, so compliance went down. So yeah, chest wall की resting thing at rest, chest wall is always expanding. So यहाँ पे we've lost the equilibrium balance because of the stab. So, and when an abnormal communication pathway is created between the lung or an exterior chest and the intrapleural space, the intrapleural pressure equalizes with alveolar atmospheric pressure, resulting in a loss of the intrapleural negative pressure. With the lung and chest wall no longer pulling each other in opposite directions, the chest wall springs out to its equilibrium position and increasing the hemithorax volume. Then the loss of negative, when an abnormal communication pathway is created between the lung and the intrapleural space. So what happened? The intrapleural pressure equalizes with the atmospheric pressure. So higher pressure atmospheric air enters and it equalizes. Alveolar pressure is equal to the atmospheric pressure. So यहाँ पे जितना बाहर pressure, it will come in and it will balance each other out. Okay, there's nothing to stop it now. So it equalizes with the alveolar and atmospheric pressure, resulting in a loss of the negative intrapleural pressure. With the lung and chest wall no longer pulling each other in opposite directions, the chest wall springs out to its equilibrium position, increasing the hemithorax volume. The loss of negative intrapleural pressure also causes the lungs to collapse towards its equilibrium position, which is the, what is this black dot they keep talking? Okay, this one. Sorry. So that's the black dot. Its equilibrium position is to collapse. So compliance is defined as change in volume per change in pressure and represented by the slope of the pressure volume curve. Slope of the pressure volume curve is compliance. High compliance is illustrated by a steep sloping curve. Yeah, if it is just the compliance, then it's a steep sloping curve. Lung compliance demonstrates hysteresis. That is, lung compliance differs during inspiration and expiration due to the effects of alveolar surface tension. We said flatness of the inspiratory compliance, lung compliance at very low lung volumes reflects the difficulty in inflating the collapsed lung and represents a decreased compliance compared to that at FRC.
One quick question. This red color wala, this graph, is it like it's showing that compliance is decreasing, right? Because it is shifting somewhere like up, right? The red dot, what they have said here.
This one?
Is like, because the blue line is the correct compliance. It's a normal compliance.
Correct.
And the red one is the decreased compliance.
Even
Even
red one is normal for the lung itself. I mean, for the chest wall. If you take chest wall just by itself, that's this red curve.
okay.
If you take just the lung on its own, this is the curve with the hysterical one. If you combine these two, the net effect of the expanding force and the collapsing force, the net effect is the blue one.
Sarah, here red dot they have written, no?
That means now the equilibrium is lost because of the stab injury. So the chest wall will go to its equilibrium point and it will become
decrease compliant, right? No?
It's going to increase compliance, I think, because it's usually negative, but it's going closer to the 0 point. I'm not sure though. Where does it say the red dot? Blue dot is
third
here.
paragraph, third paragraph's last two line.
Yeah. So with the lung and chest wall no longer pulling each other in opposite directions, the chest wall springs outward to its equilibrium position. So this is the equilibrium. Yeah. So wherever these graphs are meeting the functional residual capacity or 0 point, that is their resting equilibrium point on their own, if we see. So where this red intersects the 0 point is its own equilibrium point. And where this, in lung compliance intersects is 0, it's over here. Is its 0 point, the equilibrium point. The net effect is here when you combine the two. So compliance is,
I think in remember there is what we call in the in CVS we were having that loop diagrams were there, right?
yep.
Yeah, there. So
Yeah,
whenever the compliances go little up, we always used to say कि अरे वो decrease हो गया है, isn't it? Like, so मुझे यहाँ पे I just thought about that and I was thinking.
Again, pressure. Say whatever you're saying. Actually, maybe I'm wrong. What, say again, please?
No, this equilibrium, I got it. But what I thought through the loop diagram in the CVS, they have no. So whenever, if in the CVS, whenever the compliant line is going little up, like from the blue to red, we always include it like, the compliance has decreased. So the similar way I thought here also the compliance is decreasing. Just that thought was there in my mind about, that loop diagram was it there. But
Yeah, my brain is not correlating. But so yeah, here is the chest wall compliance increasing or decreasing. Compliance we said was the plastic bag. The chest wall will go to its resting state, which is springing outward. If it's springing outward,
Sarah, about in pneumothorax, shouldn't, this is pneumothorax, right?
yeah, this is pneumothorax, yeah.
Yeah, shouldn't atelectasis, I mean, shouldn't it be compliance decrease or no?
Yeah, if we're talking about the lung tissue, its compliance decreases. But if you talk about the chest wall, that's springing outward, right? So chest wall compliance will go up because it's pulling out. Lung compliance will go down. So it's like, what tissue are we talking about? So that's the main thing. So here chest wall, which was a negative force, became 0. So I think chest wall compliance went up. So volume, see, if you see the volume, if this is 0 or whatever number, if you put, volume went up because chest wall is taking, the cavity is having more volume now. So volume number, if you plot X, if this was, let's say 10, this became 15. Pressure, if it was initially here at this point, pressure is going up. I don't know. But yeah, chest wall compliance will go up and lung compliance will go down. So that's what is my understanding.
Sarah, I think that's right, what you said.
Yeah, so that's why, thank you. So here it said in lung compliance went down. They didn't ask for chest wall compliance, they asked the hemithorax volume. So this volume is going to go up because the ribs are, that's chest wall is going to push, like not push, like pull outward, spring outward. So the volume went up.
So the lung compliance decrease, chest compliance increase.
Exactly. Yes, that's the conclusion.
Okay. Thank you.
Thank you.
Sorry, what's the conclusion? Sorry, what's the conclusion? The final
conclusion is here in the case of a pneumothorax or any stab injury, there's this equilibrium is lost. Correct? Number 1, equilibrium is lost. So in unko apni apni marzi ka karna hai. Lungs like to collapse. So they will collapse. So that means they are not going to behave like the plastic grocery bag we said. So they are going to shrink. So compliance will decrease. Lung compliance decreases. Chest wall want to do their own thing, which is they like to spring outward. They're outgoing. They go out. So compliance, so this one will behave like a bigger grocery bag, right? The chest cavity. So compliance of the chest wall will go up. Agreed?
Oh yeah. वो बाहर की तरफ जाएंगे और lungs अंदर की तरफ सुकड़ जाएंगे. Okay.
Exactly. Yes.
Thank you.
That's the conclusion. So compliance of lung goes down. Compliance of chest wall goes up. That's the conclusion. Yeah, this graph plotting is
thank you.
But I think got a little bit of fold. So then, yeah, hysteresis also I think we got. So lung inflation follows a different pressure volume curve. Inflation, which is inspiration, during inspiration. I think this is a good image of the hysteresis. Kang, yeah. I think it was another question. Okay. So this initial flatness is because it's trying to push against the surface tension. It's trying to fight the surface tension. Then once it overcomes, it's able to fill in and inflate. So then lung inflation follows a different pressure volume curve than the lung deflation. Deflation, nothing is stopping it. So it likes to collapse, right? Lung likes to collapse so easy. So the lung So lung inflation follows a different pressure volume curve than the lung deflation due to the need to overcome the surface tension forces in inflation or inspiration. So this phenomenon is known as hysteresis. Okay, so that's kind of done with this page. How are we doing on time? Should we do one more and stop, or should we just stop?
I think we should just stop. This is very complex thing.
Yeah,
Need fresh mind.
Yeah, this is another heavy concept. Okay.
I agree.
Yes, I agree also. Let's stop. Okay, so let me just finish this image. What is this talking about? Transpulmonary static pressure versus volume. So yeah, the lung chest wall system, the net compliance is a balance. In emphysema, it tends to open up. So here is going higher. In fibrosis, it tends to shrink. So the net effect will be shrinking. So I think this makes sense, right? It's easier. Okay. Yes, thank you. Thank you, Fez. Okay. Okay, guys. Thank you. Thank you. Let's today stop.
Thank you so much.
Thanks to you.